Hey guys, what's up? This is Stephanie and welcome back to my channel. So in the video today, I'm going to be doing a pulmonology PANCE review. So I'm going to be going over the topics that are on the blueprint for the pulmonology section of your PANCE. So hopefully this video is helpful. I took the PANCE already, certified physician assistant, so I'm very excited about that. And I did a lot of practice questions before I took my PANCE. I went through all the ROSH review questions. I went through a lot of questions for Exam Master, UWorld, Smarty Pants. So I went through a lot of question banks, and usually what happens when you're going through a lot of question banks, you kind of see repetition in the things that they really like to commonly ask. So I made sure that I made note of that. And so hopefully this review is going to be helpful for you guys. I'll be discussing what I saw was very commonly asked in the practice questions, or on the PANCE, or on my end of rotation exams, or during my didactic year when I took my exam. So I'll be telling you the buzzwords that I saw, even though the PANCE is kind of getting away from buzzwords, but just in case you see them, I will be discussing the buzzwords or what is kind of like the new things that they asked. So hopefully this video is helpful for you guys. If I have any mistakes, please comment below so I can make sure that I edit it or put it in the description so that individuals who are listening to this video do not get the wrong information. So I hope this video is helpful. So why don't we start with obstructive pulmonary diseases. The first one's going to be chronic bronchitis. So your COPD, right? Chronic bronchitis. So, which is chronic obstructive pulmonary disease. And just in general for pulmonary diseases, right, we think about obstructive and restrictive. Usually with obstructive, the patient can get air in, but they can't get air out, right? So they're usually going to be hyperinflated. Versus restrictive pulmonary disorders, usually we think about things where the patient can't get air in, but they can get air out. That's why it's called restrictive. And with obstructive pulmonary disorders, the ones that we really think about are going to be your chronic bronchitis, the emphysema is the other one, and then the other one, which is reversible, and it's the only reversible, is going to be asthma. So we'll go through these. So chronic bronchitis, it's going to be COPD, right? So with COPD, chronic obstructive pulmonary disorders, remember we discussed it's emphysema, asthma, and then chronic bronchitis. It's an inflammation of the bronchial tubes, and these are the patients that we think about as the blue bloaters. And it's an obstructive pulmonary disease. Usually, like we discussed, a patient can't get air in, but they can't get air out. And usually pathophysiology for these patients is that they're going to be presenting with a chronic cough or sputum. They're going to have excess mucus that narrows the airway so air cannot, the patient has trouble exhaling air out. Usually this constant inflammation is going to lead to scarring, and usually the patient's going to have an enlargement in their mucus glands also. So usually this enlargement in the mucus glands, what happens is that it leads to hyperplasia, which is going to lead to obstruction, and the airway becomes obstructed and it can't empty properly. So the patient's going to be having air trapping, and that's why these patients are just really blue, right? The blue bloaters, they're bloated. And this, what happens is that since the patient is just air trapping all this air and they can't get it out, this is going to lower the expiratory capacity. So their FVC is going to be lowered, which is going to be their forced vital capacity. So the most common cause of this is usually going to be those smokers, right? Those tobacco users that just have a very, like, they've been smoking for a very long time. Other things that can cause this can be air pollution, occupational exposure. If the patient has an occupational exposure and then on top of that they're smokers, it's like a double whammy. Other things like cystic fibrosis, family history, it's more commonly found in males than females. And usually these patients are going to be presenting with a productive cough that's usually worse in the morning. They're going to have dyspnea on exertion. They're going to be overweight, cyanotic. Why? Because they're going to have chronic hypercapnia, which makes sense, right? They're retaining all that carbon dioxide, but they're going to be hypoxemic. They can't get, so they're retaining all that carbon dioxide. They're not able to get it out, and they're going to be having decreased oxygen. Also, they're going to have peripheral edema, bronchi, wheezing. Why? Because there's narrowing of those bronchial tubes, right? Crackles and rails, clubbing. Usually a clubbing, when we look on the physical exam, right, of the fingers, is just because these patients are hypoxemic or they have decreased oxygen. In addition to that, this patient is going to having a prolonged expiration, So in addition, these patients are very prone to getting pulmonary hypertension. Why? Because there's this vasoconstriction that is occurring. Also, these patients can present with right heart failure, which is where the patient's going to have those symptoms of right heart failure, right? We think about those, the edema, usually the lower extremity edema, jugular venous distension, hepatomegaly. The patients can also present with cor pulmonale, which is going to be right heart failure symptoms, plus on top of that, pulmonary hypertension. And diagnosis for chronic bronchitis is usually clinical diagnosis, and they have to meet this criteria, which is something that you need to know that is commonly tested. Is going to be a productive cough that's been going on for more than 3 months for at least 2 years. So once again, a productive cough going on for more than 3 months for at least 2 years. Labs, you're going to see an elevated hemoglobin. These patients are going to have polycythemia. They're going to have an increased respiratory rate also. Their read index is going to be greater than 40%. And usually the best initial diagnostic test for these patients is going to be a pulmonary function test. So if the question asks you what's the next step, we're going to do a pulmonary function test. And usually what you're going to see is that your patient's going to have a decreased FEV1 over FVC ratio. Usually it's going to be less than 0.7, and that's going to tell us that there's some type of obstructive process going on. They're going to have an increased total lung capacity, which makes sense, right? Because they're air trapping. They're not able to get that air out. An ABG, if you do one, they're going to be what? Respiratory acidotic, which makes sense once again because these patients are going to be what? Hypercapnic, because they're retaining all that carbon dioxide. They're not able to get it out. So treatment for these patients, once again, for the PANCE, they really like to ask, and the answer is usually going to be conservative. Unless they ask you specifically what's the next pharmacological treatment, then that's when you would choose a pharmacological treatment. But usually the initial thing that you're going to do for these patients is going to be conservative. If they're smokers, stop smoking. That's going to decrease the mortality, and it's going to decrease the progression of chronic bronchitis, going into heart failure, going into pulmonary hypertension like we discussed. Another thing that is really helpful for these patients is home oxygen, and then just ensuring that we vaccinate these patients against flu and pneumococcal vaccine, because these patients are very prone to getting bacterial infections, especially strep, right? Strep is just everywhere, especially in the pulmonary cavity, everywhere here. So medications, it's usually going to be based on the gold staging, and that really is going to be dependent on how many symptoms is this patient having. Are they having dyspnea on exertion? How long have they been having it for? Are they going to have dyspnea at rest? So this is really depending on the gold staging, but it usually involves either short-acting or long-acting bronchodilators plus inhaled steroids, and then of course making sure that we give prophylactic antibiotics. Of course, the best treatment and definitive one is going to be a lung transplant. So if this patient is just really, really sick, right, then a lung transplant is going to be needed. And like we said, the complication for this is going to be lung infections. Why? Because you have this mucus plugging that's going on everywhere. And what happens anywhere that there's stasis, bacteria love stasis. Next one's going to be emphysema. This is a different flavor of chronic obstructive pulmonary disorders. This is where we think about those pink puffers that are super duper skin, the pursed lipping, right? And what happens is that usually with these patients, they're also air trapping, right? It's an obstructive pulmonary disorder. So once again, they can't get air out, but they can definitely get air in. So with these patients, the patho is that the alveoli is going to be what's going to be damaged, right? The alveoli versus your chronic bronchitis. With these patients, what happens was that the airways were becoming obstructed, right? So you were having some inflammation, you were having excess mucus in the airways that narrow the airways versus emphysema. It's due to damaged alveoli. And once again, this is due to smoking. So usually in your question stem, it's going to be a long-term smoker. So what happens is that the alveoli are damaged, they enlarge, and then they break down cartilage, they lose elasticity, and it's difficult to exhale or get air out. And it has impaired recoil, so they don't have that elasticity when you breathe in and breathe out. They're just really, really stiff. So the most common etiology, like we discussed, is going to be smoking and tobacco use. Other things can be air pollution, occupational exposure, and once again, that double whammy. If the patient works in an area where they are exposed to bad air, or they're constantly inhaling certain things in the air, and on top of that they're smokers, then it's going to be a double whammy. Another one where it's very commonly found in patients is going to be your patients that have alpha-1 antitrypsin deficiency. So make sure that you have this in your back of your mind. Emphysema is caused by two things. It's going to be your smokers, which is a big one, and the other one's going to be your alpha-1 antitrypsin deficiency. So usually for your regular emphysema patients, the common ones that we see, it's going to be a patient that's older. They have a history of smoking, like a 20+ year pack year of smoking. Now, if you have a patient that presents and they're super young, they're like in their late 20s, early 30s, and they're presenting with emphysema, then we're thinking about alpha-1 antitrypsin. So think about this in young non-smokers like we discussed. And usually what happens with alpha-1 antitrypsin deficiency is that the alpha antitrypsin, what it does is that it inhibits elastase. So if you're not having that alpha-1 antitrypsin elastase, then the elastase is going to be overactive. There's not going to be anything that is inhibiting that elastase. So what it's going to occur is that elastase is going to be overactive and it's going to destroy the elastic tissues. So it's going to destroy that alveoli. So once again, smoking is a one cause in older patients. Alpha-1 antitrypsin is going to be those younger patients that are presenting with emphysema. So how is this patient going to present? Dyspnea, right? Trouble breathing, shortness of breath, pursed lip breathing, which is, it looks like they're breathing through a straw. And why do they do that? Because they're really trying to control their breathing. These patients are going to be very, very skinny, or they're going to be complaining of weight loss. They're going to have fatigue, hypoxemia, which makes sense, right? They're not getting oxygen through their red blood cells. Cough with sputum, or sometimes even without sputum. They're going to have that barrel chest, even though barrel chest is usually for both. So barrel chest is both in COPD, both emphysema and chronic bronchitis. So make sure you know that. So it's not only specific to emphysema, but these patients are going to be presenting with a barrel chest. Why? Because they're air trapping. In addition to that, this patient is going to be presenting with hypoxic vasoconstriction, which is going to lead to pulmonary hypertension, which is going to increase the workload on the right side of the heart, which is going to lead to cor pulmonale, and then it's going to lead to right-sided congestive heart failure. And like we discussed, the symptoms of right congestive heart failure are going to be what? That edema, right? That jugular venous ascension, that enlarged liver. So diagnosis usually with these patients we're going to see a lot of structural changes. So we can do chest x-ray. So you're going to see increased AP diameter, increased lung field lucency, flattened diaphragm. Why? Because they're air trapping. They're having that barrel chest on your chest x-ray. So once again, the best initial test for these patients is going to be a pulmonary function test. And what we're going to see is going to be similar to chronic bronchitis. So it's going to be that decreased FEV1 over FVC. They're going to have less than 0.7, which is going to be the ratio. And this tells you that there's some type of obstructive process going on. And they're going to have increased total lung capacity, which makes sense because they're air trapping. They're not able to get that air out. And for your ABC, you're going to see chronic respiratory acidosis. So once again, treatment for these patients is going to be conservative, like we discussed. Smoking cessation, that's going to help decrease mortality. It's going to help decrease that emphysema progressing into anything worse. Home oxygen, and then ensuring that we vaccinate these patients against flu and pneumococcal. And you can also give these patients bronchodilators, inhaled steroids, prophylactic antibiotics. If the patient has alpha-1 antitrypsin deficiency, then of course we're going to treat this patient with IV pooled alpha-1 antitrypsin. So the next one's going to be COPD exacerbation. This is going to be an acute worsening of any patient's respiratory symptoms, leading to a change in their treatments. These patients are going to be at risk for what type of infection? Pseudomonas aeruginosa infection. And a lot of infections can cause a COPD exacerbation. Usually we think about the common ones, which are going to be your Streptococcus pneumonia, your Moraxella catarrhalis, and then S is going to be for Streptococcus pneumonia. So Streptococcus pneumonia, Moraxella catarrhalis, and Haemophilus influenza. Usually we think about the ones that are very commonly found in like your respiratory secretions, right? So the next one that we're going to go into is, for example, what are some of the symptoms that this patient is going to present with? So they're going to have increased frequency and severity of their cough. So these patients are going to look really sick. They're going to be saying that their cough is getting worse. it's going to be even more productive. In addition to that, they're going to have an increased amount of sputum, increased production of sputum. They're going to be presenting with dyspnea, wheezing, tachypnea. You're going to see accessory muscle use. They're going to be presenting confused. And usually treatment for these patients is going to be supplemental oxygen. This is going to decrease their mortality rate. Also, you can give the patient systemic corticosteroids, and then ensuring that we give the patients like bronchodilators like ipratropium plus albuterol, so your short-acting beta agonist, and antibiotic, especially if the patient has a risk of Pseudomonas infection, like are they in the hospital, are they admitted, are they in the ICU, and just how can we prevent these COPD exacerbations? Like we discussed earlier, vaccination. So vaccinating these patients annually against influenza vaccine, vaccinating them against a pneumococcal vaccine, especially any patients that's older than 65 years old. So the next one's going to be asthma. Like we discussed, this is going to be an obstructive pulmonary disorder, but the difference is that this one is going to be, in comparison to bronchitis and emphysema, is that this one is reversible, and that's a key, right? So this one's going to be reversible. What happens is that the patient has narrow airways, so the airways are going to be narrowed, and this is going to cause the patient to have trouble breathing. So usually they're going to be presenting with a triad of airway inflammation, hyperactivity, and then we said reversible obstruction, and that's a key for this one. And usually the pathophysiology is that they have certain triggers that cause the patient to have an asthma attack. So for example, excessive reaction from immune cells due to cytokine release, so there's a release of histamines, leukotrienes, and prostaglandins. Also, what happens is that the airway gets narrows, which causes increased mucus secretion, increased vascular permeability, and if the patient's been having this for a long time, then what's going to happen is that they're going to have edema, scarring, and fibrosis. And sometimes if this is chronic, then what happens is that it goes into an irreversible obstruction. So some of the things that can trigger asthma can be environmental things, right? Genetics, family history, and usually we think about our atopic triad, so anything that's IgE mediated, and that's usually what I look for in the question stem, is that the patient's usually going to have these three things: asthma, atopic dermatitis, your eczema, and then allergic rhinitis, or allergies, atopic dermatitis, and also your asthma. That's going to be your atopic triad. And this patient can present with either extrinsic or intrinsic. So extrinsic usually develops early, so extrinsic asthma, and it's usually due to type 1 hypersensitivity reaction, so it's due to IgE, and this is where the patient presents with your atopic dermatitis. Discuss that atopic triad of atopic dermatitis, so the eczema, your allergies, and then the asthma, because why? This is IgE mediated. And things that trigger it, it's going to be environmental things, right? Is there someone smoking in the house? Is there some mold? Is there pollen, pets, dust? And usually these patients have a strong family history. Next one's going to be intrinsic. This usually develops later in life. So it's interesting, during my family rotation, we were diagnosing a lot of patients with asthma that were adults, and they would tell me, like, I never had asthma as a child and understand why I'm presenting now with asthma. And it would be patients that were coming in with this chronic cough that was usually exacerbated whenever they went outside, whenever they walked into a cold environment or just a humid environment. And so usually with these patients, we think about intrinsic, right? It develops later in life. Triggers can be aspirin, beta blockers, infections, cold, like I discussed, inhaled irritants like smoke, and even exercise. So just make sure you know the difference between both of them. So once again, extrinsic, we think about usually our children, versus intrinsic is usually later in life. So how is the patient with asthma going to present? So they're going to be presenting with intermittent symptoms. So they're going to have shortness of breath, wheezing, chest tightness, cough. During my pediatric rotation, I got really good in hearing wheezes because a lot of our patients had asthma, and they're really wheezing. Like, you'll see them and they're fine, but when you listen to them on auscultation, you can hear the wheezing. So with these patients, they're going to be presenting with chest tightness, cough. That's usually worse at night, and usually the wheezing is going to be when on expiration. So the wheezing is going to be on expiration. If a patient has an acute asthma exacerbation, they're going to be looking really sick. They're going to be tachypnic because they're really trying to catch their breath. They're going to be diaphoretic, wheezing, They won't even be able to complete their sentences whenever they're speaking. You're going to see that accessory muscle use. Whenever you see a patient in general, whether it's a child that's coming in, a baby with RSV, and you're seeing that accessory use, is because they're really having hard time trying to get oxygen in. So these patients you really need to worry about. So it's going to be that accessory muscle use with these patients, intercostal retractions, diminished breath sounds whenever you auscultate on them, fatigue, right? And then usually chronic asthma, we think about our SAMTER triad, which is going to be asthma, the nasal polyps, which are really inflamed inside the nasal mucosa. And also another thing you're going to see is usually aspirin or NSAID sensitivity, and that's usually the SAMTER triad. Diagnosis is going to be your PFT, and that's what you're going to do with these patients, your initial test, so your peak expiratory flow rate. And you can also do a chest x-ray. Usually we do a chest x-ray for our first-time wheezers, but it's usually going to be normal. If the patient has severe asthma, then you can see like hyperinflation, but usually chest x-ray is normal. I've had questions where I ask you, what do you expect to see on a chest x-ray for a patient with asthma? It's going to be a normal chest x-ray. That's all it is. I mean, you might see some hyperinflation, but majority of the cases, it's a normal chest x-ray. So with the forced expirational volume, what you're going to see is that an increase in forced expirational volume greater than 12% with albuterol. So what you're going to do is that you're going to give a patient albuterol, which is going to be a bronchodilator. It's going to dilate those airways, and it's going to make the patient breathe better. So they're going to have an increase of 12% or more than 12% in their forced expirational volume. And you can be mean and give them something like methacholine or histamine, which is further going to which is going to further constrict those airways, and so the patient's going to have a decrease in FEV1 greater than 20%, and that's usually diagnostic for these patients. And another thing that you need to know is the stages of asthma, and it's really important that you know the stages of asthma because you need to know how you're going to treat your patients. I can guarantee you that you are going to have one or even two questions on your PANCE, if not more, for how to treat the patient and what stage they're in. This is something that's very commonly tested, and it's really important that you know. So stages of asthma, we have our intermittent asthma, mild persistent asthma, moderate persistent, and then we have severe persistent asthma. So in a patient with intermittent asthma, just like it sounds, it's intermittent, it comes and goes. This patient's going to have symptoms less than 2 days per week, and they're going to use their rescue medication like Asaba, which is a short-acting beta agonist. The common one's going to be albuterol. So they're going to use this less than 2 days per week, and they're going to have night symptoms less than twice per month. Their forced expirational volume, or their FEV1, is going to be greater than 80% predicted, and they're going to have a normal ratio. So the treatment for these patients is we're going to do the first step, which is going to be Asaba. Everyone gets Asaba. It's like Oprah, right? You get Asaba, you get Asaba, and you get Asaba. Everyone gets Saba in your asthma. So once again, Saba, short-acting beta agonist. And it's going to be which one? Your albuterol. So that's going to be your intermittent, and it's going to be albuterol as needed. So if the patient feels like they're short of breath, educate them, use your albuterol. The next one's going to be your mild persistent asthma. This patient's going to have symptoms more than 2 days per week. They're going to be using the rescue medication more than 2 days per week, and they're going to have night symptoms 3 to 4 times per month. Their forced expirational volume is going to be greater than 80% predicted, and usually it's going to be a normal ratio also. So with these patients, how are you going to treat them? So you're going to go onto your second step. So you're going to have a Saba. Remember, everyone gets Saba, you get a Saba, you get a Saba, you get a Saba. So you're going to add albuterol, you're going to have albuterol, and then on top of that, you're going to add a low-dose inhaled corticosteroid. So something like fluticasone. Then you have your moderate persistent asthma. So with your moderate persistent asthma, the patient's going to have daily symptoms. So you're going to use your rescue medication every day. They're going to have night symptoms more than once per week. The forced expirational volume is going to be greater than 60%, but it's going to be less than 80% predicted. The ratio is going to be reduced by 5%. And this is where we're going to move on to step 3. So we said everyone gets a Saba, right? So it's going to be a Saba plus low-dose inhaled corticosteroid like fluticasone, plus on top of that, you're going to add a long-acting beta agonist. So you're going to add something like salmeterol, which is going to be a long-acting beta agonist. Or, of course, another thing that you can do is you can do a Saba, like albuterol, plus a medium-dose inhaled corticosteroid, or a Saba plus leukotriene and or like theophylline, right? So the next one's going to be severe persistent. This is where the patient has symptoms continuously, so they're going to have symptoms multiple times throughout the day. They're going to use the rescue medication multiple times throughout the day. They're going to have night symptoms more than 7 times per week. So that's going to be like almost every day out of the week at night. Their forced expirational volume is going to be less than 60%. And the ratio is going to be greater than 5% lower. So treatment for these patients is usually going to be step 4 and 5. So you're going to do a SABA. Everyone gets a SABA plus a medium inhaled corticosteroid or a high dose inhaled corticosteroid plus a long-acting beta agonist. So like I said, everyone gets a SABA. You get a SABA, I get a SABA, but everyone gets a SABA for asthma. And it's really important that with these patients, we educate them, right? Avoid anything that is causing or exacerbating the asthma. Avoid the triggers. And it's really important that with these patients, you step down. So if the patient, for example, was a mild persistent asthma, so they were on a SABA and then they were on an inhaled corticosteroid, and then they're getting better, like they're having symptoms that are less than 2 days a week, so they move back to the intermittent stage of asthma, then maybe just take away the inhaled corticosteroid and the patient can just stay on the SABA, right? So that's why it's really important that if the patient is controlled for more than 3 months or they're having better reduced symptoms, then we're going to step down with these patients. If the patient is having an acute attack of asthma, then with these patients, the best initial thing we can do is do a SABA, so a short-acting beta agonist. Second line is usually like IV methylprednisolone. And of course, if we need to intubate these patients, then we're going to be intubating with these patients because a lot of patients can die from acute asthma attacks, right? We can also give magnesium for these patients also. Another thing that you need to know in regards to patient education is just educating patients on how to use their inhaled corticosteroids, right? So making sure that after they use it, wash your mouth because these patients are very prone to getting secondary candidal infections in the back of their throat. So the next topic we're going to go over is going to be your pneumonias. This is something that is very commonly tested, and I can guarantee you're going to get a question on. So pulmonology is about 10% of your PANCE, so it's really important that even though it's not that many things on your blueprint, it's really important that you know them well because these are gimmies and they're easy points in the PANCE if you know this material well. All right, guys, so let's go into our infectious disorders. So infectious disorders, why don't we start with acute bronchitis? This is going to be an inflammation and infection of the bronchi, usually the lower respiratory tract, and usually it's preceded by an upper respiratory tract. The most common cause of bronchitis is going to be viral, not bacterial. Most common cause of bronchitis is going to be viral. And this is really important that you know because this is going to tell you how you're going to treat the patient. Since the most common cause of bronchitis is viral, usually these patients get supportive care, right? So once again, most common cause is going to be viral, usually due to influenza, parainfluenza, RSV, coronavirus, and adenovirus. Bacterial definitely can cause also bronchitis. And when we do think about infections that cause, or bacteria that can cause bacterial bronchitis, usually we think about Bordetella pertussis, right? Mycoplasma, even chlamydia. Signs and symptoms, usually patients going to be presenting with cough, with or without sputum for about 1 to 2 weeks. They're going to have dyspnea, so painful breathing, sore throat, shortness of breath, congestion. They can present with a fever. They can also present with hemoptysis, so just make sure you keep that in mind. I know sometimes when we think about hemoptysis, we think about tuberculosis or lung cancer. No, patients with acute bronchitis can also present with hemoptysis. Usually with these patients on physical exam, you're going to hear bilateral rhonchi and wheezing, and that's a key for this one. Diagnosis is going to be clinical. If you suspect that it's due to bacteria, you can do a sputum culture. And then usually if you do a chest x-ray, it's going to be normal, right? And like we said, the most common cause of acute bronchitis is going to be a viral infection. So that's why supportive care is going to be the treatment of choice for these patients. So we'll give them cough suppressants, things dextromethorphan, also guanfacine, which is going to be your anti-cough medications, right? Bronchodilators, fever reducers, and like I said, antibiotics are not indicated because the most common cause of acute bronchitis is going to be a viral infection. Next one's going to be acute epiglottitis. This is going to be life-threatening. This is going to be a bacterial infection of the epiglottis. What happens is that there's a rapid inflammation or swelling of the epiglottis that reduces the upper airway. Some of the causes by far is going to be, of course, unvaccinated children between the ages of 3 to 7. and the most common organism is going to be Haemophilus influenza type B, which is going to be a gram-negative rod. Now, for ROSH review, I kept getting a lot of practice questions in regards to epiglottitis, and just make sure that you're reading the questions to them. If the patient is vaccinated, the most common cause is going to be either staph or strep, right? If it's an older patient, we assume that they're vaccinated, it's going to be staph or strep for acute epiglottitis. If it's a child and the question stem clearly states that the patient is unvaccinated, then that's where you're going to think that Haemophilus influenza type B is the answer choice or is the culprit for this infection. Just watch out for that because it will trick you. So once again, epiglottitis, very commonly found in your unvaccinated, but it can also, in vaccinated children, it can also be found in your adults. If it's unvaccinated, the patient is unvaccinated, then we think about Haemophilus influenza type B. If the patient is vaccinated or if they're older, we think about either staph or strep. So how is this patient going to present? They're going to have a rapid onset, 1 to 3 hours, high fever, sore throat, and usually we think about our 3Ds, right? Drooling, dysphagia, and distress. They have that potato voice, right? They're going to be very anxious appearing. They're going to have that tripod positioning where they're literally like sitting like that because they're trying to keep their airway open. Hyperextended neck, right, with the protruding chin. Also, they're going to have slow or labored respiration rate, soft inspiratory stridor, and that's a key. It's going to be inspiratory stridor, right? Not expiratory, inspiratory stridor. Retractions, late cyanosis, and they're going to appear toxic. Diagnosis is going to be a lateral neck x-ray, and that's where you're going to see your thumbprint sign. You can also do a throat culture for Haemophilus influenza type B, right, for these patients. We want to make sure that with these patients, we don't stick anything down the throat. So we don't put anything down the throat. We don't try to do anything that's going to further aggravate that throat. So first thing that we need to do for these patients, and the question is going to ask you what is the next step, is going to be airway management. So it's going to airway management. That's going to be the answer in the OR. If you need to insert an endotracheal tube, then do it. Put the patient on oxygen, right? You want to make sure that you prepare the patient for intubation. So you establish that airway, and that's going to be the first thing. If you need a tracheostomy, then you do a tracheostomy. And then that's when you can give the patient AV antibiotics. So usually we're going to give them 3rd generation cephalosporins like ceftriaxone plus an anti-staphylococcal agent like clindamycin or vancomycin. You can also give them corticosteroids. So once again, your acute epiglottitis, this is life-threatening. That tripod position, those 3Ds, right? Dysphagia, that drooling and distress. This patient's going to have inspiratory stridor, that hot potato voice, right? We're going to do a chest x-ray. You're going to see that thumbprint sign on your x-ray. And the culprit, unvaccinated Haemophilus influenza type B. If the patient's vaccinated or if they're an adult, it's going to be either Staph aureus or strep. And treatment, first thing you're going to do is your ABCs, right? Airway, brain circulation. Make sure that you are managing that airway in the OR, giving the patient oxygen, intubating, and then after that, you're going to give them IV antibiotics. Next one's going to be acute bronchiolitis. This is going to be an inflammation of the smaller airways. Usually there's going to be an increased amount of mucus production, and what's going to happen is that those airways are going to narrow, they're going to bronchospasm, and they can also cause obstruction. Very commonly found in your little babies, children under the age of 2. It tends to peak between 2 to 6 months, and it's usually seasonal, especially during the winter months. And this is very commonly found in patients that are preemies, right? Also, your patients that have like heart problems, like congenital heart problems, like your atrial septal defect, right? Your VSD, very prone for these patients. Also, if they have Down syndrome, very prone to getting these infections. And that's one of the things that you really need to take into consideration when admitting this patient is what does this patient have? Like what, for example, are they immunosuppressed? Do they have Down syndrome? Do they have any heart problems? Are they preemies? And that's what you take into consideration whether the patient needs to be admitted or discharged. They can go safely home. And then, of course, how is the patient presenting? And this is caused by a virus. Always, it's going to be your RSV, right? This is very, very contagious. This patient is going to be presenting with coughing, congestion. You're going to have bilateral wheezing also, clear rhinorrhea, fever, dyspnea, prolonged expiratory phase, and clubbing also. And usually when we think about clubbing, usually that's a sign of hypoxia. Poor feeding. And the keyword for this one and how I see it on the question stem is going to be that nasal flaring. And also another one you're going to see on your question stem is going to be that grunting, those retractions, right? Air trapping, hyperresonance of the lungs, right? Because they're air trapping, apnea. Diagnosis is usually clinical. You can measure their pulse ox, which is usually going to be decreased. You can do a chest x-ray. Sometimes you'll see an atelectasis, especially if there's like a mucus plug there. And treatment is just going to be supportive, right? Hydration, fluids, nasal suctioning, antipyretics, and oxygen. The treatment for this is really controversial. I've heard podcasts where there's doctors that recommend steroids, and then there's doctors that don't recommend steroids. So it's really, really controversial. It's really supportive, and just ensuring that you give the patient fluids, hydration, nasal suctioning, right? Controlling that fever, giving the patient oxygen. And if the patient is very severe, if they're really using their lungs, right, and you see them and they look very, very sick or their oxygen is really low, then these patients get admitted. And like I said, if the patient also if they're preemies, if they have any heart conditions, Down syndrome, for example, then these patients also get admitted. And when you do get admitted, you give them IV fluids, humidified oxygen, CPAP, and then also these babies might even get intubated. So the next topic we're going to go over is going to be RSV, respiratory syncytial virus. This is transmitted via droplets when someone sneezes or coughs, and usually it targets the respiratory epithelial cells. The most common virus involved is going to be your paramyxovirus. It's the leading cause of hospitalization in children under the age of 5. And like we discussed, right, acute bronchiolitis is usually associated with RSV. And usually RSV is very common during the winter and very common in your patients, your children that are preemie babies. They have any heart conditions like we discussed, any neurological problems. Also, RSV is very commonly transmitted in daycares. And this patient is going to be presenting with a low-grade fever, tachypnea, which is that breathing super duper quickly, rhinorrhea, coughing, wheezing, dyspnea, so trouble breathing, cyanosis, retractions, hyperinflated lungs, headache. And diagnosis, usually with these patients, we can do a chest x-ray, a CBC, a throat swab, or a PCR. Usually on your chest x-ray, you'll see atelectasis or air trapping. And treatment for these patients is usually supportive, right? Because once again, RSV is a virus, so it's going to be a viral infection, so we do supportive care. So we'll do things like hydration, humidification, ventilatory support. And with these patients, we can give them something like bronchodilators and corticosteroids, but usually with these patients, right, and like we discussed with bronchiolitis in general, there's not really a specific treatment for them because there's so many controversies whether steroids are helpful or whether bronchodilators are helpful. But just for the exam, make sure that supportive care is usually the treatment of choice, hydration, humidification, ensuring that the patient does not become hypoxic. And just ensuring that patients that look really, really sick, we admit them, right? We don't discharge them. So it's going to be your high-risk children, preemies, like we discussed, immunocompromised, and usually these patients that are immunocompromised or they're preemies, like they have any heart conditions, we'll usually give them something like palivizumab, which is a monthly injection, and this helps them protect them against RSV. Or if it's a child just having recurrent RSV infections, then palivizumab is really good for these patients. Next one's going to be croup. This one's also known as your laryngeotracheobronchitis. Make sure you know that because sometimes they'll put that as an answer choice instead of croup. So you're reading the question stem and you're like, I know what it is, right? It's that croupy cough, that seal-like barking cough, and then they don't have croup as an answer choice. They have something like laryngeotracheobronchitis. So make sure that you know that. So what is croup? It's an inflammation of the upper respiratory tract, and what happens is that there's a narrowing of what the subglottic airway. So narrowing of the subglottic airway, this is another thing that they really like to test you in regards to your endorotation exams, PA school, the PANCE is what is the pathophysiology, what's going on, and it's going to be that narrowing of the subglottic area. And the most common virus involved in croup is going to be parainfluenza virus and influenza virus, very commonly found in your younger children, once again, so 6 months to 3 years old, common during the fall and winter, and it tends to affect more males than females. And usually with these patients, make sure that you also have the differential diagnosis of bacterial tracheitis, because it sounds very familiar, right, to laryngotracheobronchitis. And the difference between both of them is that with bacterial tracheitis, the patient's going to be older, so it's going to be a 3 to 5 year old, and it's going to present very similar to croup, so they're going to have that barking cough, right? But the difference is that this patient's going to be looking very toxic appearing. Sometimes they might even be even in a position where they're really trying to protect their airway, and this is going to be an airway emergency. These patients are going to get, we need to make sure that we treat them as soon as we can, right? We protect that airway. If they need to get intubated, intubate them. So make sure you know the difference between croup and bacterial tracheitis. Bacterial tracheitis is, like it says, bacteria, usually due to bacteria, versus croup, it's usually due to parainfluenza virus. Bacterial tracheitis, it's going to be usually in older patients, 3 to 5 years old. It's going to present very similar to croup, but the patient's going to be looking very toxic appearing. They're going to be looking very sick. And in these patients, we want to make sure that we protect that airway. So for croup, diagnosis is we're going to do a chest x-ray. That's going to be our initial for all patients. And on your chest x-ray, you're going to see that steeple sign or that subglottic tracheal narrowing, right? Because like we discussed, the pathophys is that narrowing of the subglottic airway. So treatments, since this patient is and has croup and it's due to what? Parainfluenza virus, it's a viral infection, usually just conservative, so hydration, cool humidified oxygen. If the patient has severe croup, then in these patients we give them racemic nebulized epi plus either oral or intramuscular dexamethasone. And how are you going to tell the difference between a regular mild case of croup and a severe croup is that in a severe croup, usually the patient is going to have those intercostal retractions even at rest. So that's when you're thinking that this is going to be a severe case of croup. The next one's going to be influenza. So influenza, it's usually due to, of course, the influenza virus, right? It's a base of hemagglutinins and neuraminidase. For example, H3N2, we think about H1N1. This one spreads via droplets, and it's very, very contagious. This is the one that causes your annually epidemics, very commonly found during the winter. And the virus that is responsible for causing influenza is going to be an RNA virus. So it's going to be your orthomyxovirus. So make sure you know that. I've seen question systems where they ask you that. So orthomyxovirus. And there's different types of influenza. We have A and B. By far the most common type is going to be type A, and type A is going to be the most severe type also. So diagnosis is going to be a clinical diagnosis for influenza. You can do a rapid antigen test, right? Usually this is done via PCR, so this is where you do the throat swab. And treatment is usually supportive. You can give oral oseltamivir or Tamiflu, but the key for this one and how they really like to test you for this one is who can you give Tamiflu to? Who qualifies for oral oseltamivir? So only if the patient has had symptoms within 48 hours do they qualify for Tamiflu. So you can give a patient Tamiflu if they present, for example, on the first day of symptoms, second day of symptoms. After that, Tamiflu is not helpful and it's not indicated. This is something that they really like to test, so make sure that you know this. So for example, if it's a patient comes in and they're 3 days or 4 days out of symptoms, I would not suggest oseltamivir or Tamiflu because it's not going to be helpful. So make sure that you know that and you're reading the questions then because they really like to ask you this. And usually, right, influenza, it's going to be supported like we discussed. It goes away in a week. But how can you prevent this? So you can prevent this by ensuring that you get your vaccine. You can either get the live attenuated influenza virus nasal spray vaccine or the trivalent vaccine, right? And then just make sure that we know that the live vaccines are contraindicated in pregnancy. And some of the complications, if influenza is not treated, is we think about pneumonia. It's the most common cause of viral pneumonia in adults. And croup, also acute otitis media, bronchiolitis, like we had discussed, sinusitis. So by far, pneumonia is one of the most common causes of viral pneumonia in adults. Next one's going to be pertussis. This is going to be your whooping cough, right? The whooping cough. It's due to Bordetella pertussis, which is a bacteria. It's a gram-negative bacteria. This is another way I've seen it asked, is what type of bacteria is it? Once again, it's a gram-negative bacteria. It's very, very contagious in droplets. So the thing about pertussis that you need to know is the different stages and when the patient presents more infectious during what stage, and also what stage has the whooping cough and what stage involves recovery. This is something that's very highly tested. I see this on a lot of practice questions. So it's really important that you know the difference between each stage. So you have catarrhal stage, which is going to be the first stage. You have your paroxysmal stage, which is going to be your second stage, and then your convalescent stage, which is going to be your third stage. So your catarrhal stage is going to be 1 to 2 weeks. Usually the patient's going to be presenting with those early cold-like symptoms like your cough, nasal congestion, rhinorrhea, and fever. During this catarrhal phase is when the patient is most contagious. So usually we think that it's during when the patient develops that whooping cough, but it's not. During the catarrhal phase, when the patient's having these cold-like symptoms of a cough, nasal congestion, rhinorrhea, and fever, this is when the patient is most infectious. Now, after that, you have the paroxysmal stage. This is 2 to 6 weeks later. This is where the patient starts presenting with that whooping cough, right? They have those coughing fits where they're coughing, and they have that inspiratory whooping cough, and then also they have that post-tussive emesis, which means like they throw up because they're just coughing so much. That's going to be the paroxysmal phase. So we said once again that the catarrhal phase is going to be the phase where the patient's going to be most infectious. The paroxysmal phase, that's when the patient develops that whooping cough, those coughing fits, that post-tussive emesis. And then you have your convalescent stage. It's going to be 2 to 3 weeks where the patient has gradual recovery, but they're susceptible to other infection. So once again, know the 3 stages. Paroxysmal stage is going to be the second stage, that whooping cough. The first stage is going to be your catarrhal phase, is where the patient's most infectious, and your third stage is going to be the convalescent stage, where the patient's getting better. So diagnosis for this, we'll do a CBC. We're going to see increased lymphocytes. We can do a culture of the nasopharyngeal secretions. We can also do a chest x-ray, and usually you'll see atelectasis, especially during the paroxysmal phase, because a lot of these patients will have a mucus plug that goes into the bronchi and just collapses the lung. So treatment for these patients is, if it's an infant less than 2 months old, we make sure that we give them antibiotics and we vaccinate. And the antibiotic is usually a macrolide, something like azithromycin, erythromycin, or clarithromycin. I've seen question stems that go back and forth between erythromycin and azithromycin, but just make sure that you know it's a macrolide. Being that there's a lot of resistance, now they're using more azithromycin than erythromycin, but just know it's a macrolide. By far the most common one is going to be azithromycin that I kept seeing in question stems. And just make sure that we monitor these patients. And then pertussis can be prevented. So it's prevented by the vaccine, right? DTaP, which are given in 5 doses before the patient before the patient starts school. So between 4 to 6 years old is when they're going to have their last dose. And then you have your Tdap, right? This is where there's a booster vaccine at 11 or 12 years old. And basically pertussis can be prevented. Also, pertussis is not only found in children, pertussis can also be found in adults. So make sure that you have that in the back of your mind. If it's a patient that comes in and they have a cough that's been going on for a very long time and they have these coughing fits, think about pertussis. They might trick you like that. So if you're reading the question stem and you're like, but it's an adult, it's probably pertussis. If they're having a cough that's been going on for this long time and they're saying that they're having these coughing fits, that post-tussive emesis, then think about pertussis. Interestingly, children can actually give pertussis to dogs, which I thought was very interesting. The next one's going to be pulmonary tuberculosis. This is going to be a bacterial infection of the respiratory system due to what type of bacteria? It's due to Mycobacterium tuberculosis. It's transmitted through respiratory droplets. And usually when we think about tuberculosis, we think about immigrants, we think about IV drug users, patients that are immunocompromised, like patients that have HIV or AIDS, diabetics, prisoners, homeless shelters, hospitals, and nursing homes. So any areas that are very, very congregated where transmission is very easily. How is this patient going to present? So they're going to have a chronic cough. It can or cannot be productive. They're going to be complaining of hemoptysis, which is going to be that bloody cough. fever, fatigue, night sweats is another key for this one, weight loss, anorexia, and then also erythema nodosum. So diagnosis, it's really important that you know what's the initial step you're going to do, and then after that, what's the next step you're going to do, and then what are you going to do to confirm it? That's how they like to ask you. So if it's a patient, the initial thing you're going to do that you suspect TB is going to be your PPD, right? And usually it's going to be positive. Then after that, you're going to do a chest x-ray. On the chest x-rays, you're going to see cavitary lesions. Usually they're going to be apical, right? So cavitary lesions that are apical, make sure that you look for that on your chest x-rays. They might give you a chest x-ray with the patient presenting with the symptoms that I described. And then also sputum culture is going to be usually your definitive. So you're looking for that acid-fast bacilli. So any patient that becomes positive, that has a positive PPD, they all get a chest x-ray and a sputum stain, like we said. So once again, PPD, if it's positive, next thing you're going to do is a chest x-ray, positive on the chest x-ray, then you're going to confirm it with a sputum stain, looking for that acid-fast bacilli. Now, another thing that they really like to test you is in regards to the PPD itself. So what is positive? What is considered positive for what population? So if it's more than 5 millimeters, it's positive in patients that have HIV, if they had any type of recent tuberculosis contact, or organ transplant, or immunosuppressed. If it's greater than 10 millimeters, it's positive for immigrants, IV drug abusers, diabetics, chronic renal failure, children under the age of 4. This is where they really like to get you, is in this one. So children under the age of 4, if they're greater than 10 millimeters on their PPD, it's going to be positive for them. And then also us as healthcare workers. Greater than 15 millimeters is going to be any person without known risk factors, so it's going to be any regular person. So treatment for these patients, usually your RIPE therapy, right, which is going to be your rifampin, isoniazid, pyrazinamide, and your ethambutol. And we usually give this for 6 months, and it's really important that we supplement this with vitamin B6. And the reason why is that isoniazid is usually associated with neuropathy. And so if the patient is not being given vitamin B6 in addition to the RIPE therapy, they can get peripheral neuropathy or just neuropathy in general. So make sure that you know this. It's something that's very highly tested. I had a question once where it was a patient, they were on their treatment and they were complaining of like neuropathies, right? And it asks you, how could this have been prevented? Well, it could have been prevented if we would have given the patient vitamin B6. We also make sure that we report the cases to local and state agencies and repeat the chest x-ray and sputum test to confirm the treatment. Also, we want to make sure that we monitor LFTs because isoniazid is also very known for its hepatotoxicity. So usually, another thing that they really like to test you is in regards to latent TB. So latent TB is usually a non-clinically active tuberculosis. Usually there's bacteria in the body, but they do not cause any symptoms, and this patient is not contagious, but they're going to have a positive PPD, but a negative chest x-ray and sputum. So usually with these patients, we treat them with 9 months of isoniazid plus vitamin B6, right? This is usually TB prophylaxis because we want to make sure that we decrease the spread of tuberculosis before the patient becomes active with tuberculosis. Another thing that they like to test you is the side effects of the RIPE, something that's very commonly tested. So rifampin, right, it causes those orange colored tears. And then we said isoniazid is going to be your hepatotoxicity, neurological problems, and that's why we give vitamin B6 in addition with isoniazid. And then we have also pyrazinamide, and then we have ethambutol. So ethambutol is usually associated with your eye discoloration. And the thing about ethambutol and how I memorize it is that E is for eye, so patients are going to have a decreased visual acuity, red-green discrimination, and that's a key for this one, right? It's going to be decreased visual acuity, red-green discrimination, optic neuritis, and then we said that rifampin is going to be those red-orange tears. We said isoniazid is known for causing like neuritis, like we discussed, that's why we give vitamin B6. Iron also accumulates in the mitochondria, so the patient can get sideroblastic anemia. And then we said it's hepatotoxic also. And also isoniazid is associated with lupus, so systemic lupus erythematosus. And then pyrazinamide is usually associated with hyperuricemia, so gout. And then we said ethambutol is going to be that decreased visual acuity and red and green eye discrimination. So this is something that's very commonly tested, so make sure that you know this. So let's go into our pneumonias. So we have bacterial pneumonias. So bacterial pneumonias, we usually think about our typical community-acquired pneumonias, right, which is an infection of the lung due to microbes. And what happens is that it brings water into the lungs and it makes it difficult for the patient to breathe. The pathophysiology is that microbes colonize the alveoli, and then what happens is that there's an inflammatory response. So you have white blood cells, protein, and fluid that go into the alveoli. The etiology for this is going to be smoking. You'll find fluid in the lungs, refusion, COPD, and asthma, congestive heart failure, splenectomy, immunosuppressed. Patients that are older than 60 are very prone to getting pneumonia. Alcohol abuse, right, because these patients are aspirating. Proton pump inhibitor use. Also, why? Because you're disrupting that gut flora, the stomach acid, which protects you against certain bacteria. So how is this patient going to present? They're going to have a sudden onset of productive cough. It can either be a bloody sputum or it'll say it's a pus in the sputum. So it's going to be a productive cough. And that's how you can kind of differentiate between the other types of pneumonias, is that with your typical community-acquired pneumonia, it's going to be that productive cough. The patient's going to have high fever, chills. If the patient's rigoring, then this is bad and it's going to turn really bad soon. So this patient is going to be presenting with fatigue, dyspnea, shortness of breath, tachycardia, tachypnea. On your physical exam, you're going to see dullness to percussion. They're going to have increased tactile fremitus, late inspiratory breath sounds, rouse and rhonchi, bronchial breath sounds, and then you'll see also bronchophony and egophony on your physical exam. So what does that mean? E, you're able to hear it very good on your physical exam. So you tell the patient to say E, E, and you're able to hear it clearly. Why? Because sound travels better through solid. And since they have a lot of junk in there, right, that's solid, that's why sound travels easier. So you're going to see egophony with these patients. So the thing that they really like to test is in regards to the bacteria that are involved with typical community-acquired and how are they going to present. So the typical community-acquired pneumonias, we think about Streptococcus pneumonia, Klebsiella, Staph aureus, and then things like Fusobacterium, Pseudomonas, and Haemophilus influenza. So let's go into each one. So Streptococcus pneumonia by far is the most common type of all pneumonias. It's the most common type of community-acquired pneumonia. And once again, most common type of all pneumonias. For repetition, Streptococcus pneumonia, most common bacterial infection of all bacterial pneumonias, and just most common overall in general. So Streptococcus pneumonia, most common bacterial pneumonia. And usually with Streptococcus pneumonia, you think about that rust-colored sputum. The patient's going to be presenting with those rigors, right? And it's going to be a gram-positive paired lancets, what you're going to see on your gram stain, because it's a gram-positive bacteria, right? Streptococcus. Klebsiella is going to be that current jelly sputum. Usually we think about alcoholics, right? And then you'll see on your chest x-ray bulging fissures. So once again, current jelly sputum, alcohol abuse. Haemophilus influenza, very commonly associated with your COPDers. So if your question stem, chest x-ray, you look at it, you're like, this is pneumonia, right? You're seeing those consolidations on your chest x-ray on the lobes, and it's a COPD, we think about Haemophilus influenza. And this is what type of bacteria? It's a gram-negative bacteria. And on your gram stain, you're going to see a gram-negative pleomorphic rods. Next one's going to be Staph aureus. Staph aureus, usually we think about IV drug abusers. Also very commonly found in your patients that just got better from the influenza, post-influenza. And also with this one, it's very commonly found in your elderly patients, and you're going to see a gram-positive cocci in clusters. So once again, Staph aureus, this one's very commonly tested. Make sure you know this. IV drug abusers, post-influenza. Staph aureus really likes to create abscesses. It's one of the bacteria that are very known for just looking really ugly. So if you see anything that's loculated on the chest x-ray, the bacteria you might be thinking about is going to be what? Is Staph aureus, because this one really likes to cause abscesses in comparison to all the other ones. Next one's going to be Pseudomonas, very commonly found in who? Cystic fibrosis, right? Also nursing homes. There's usually this patient's going to be presenting cyanotic. Next one's going to be Fusobacterium. Usually we think about aspiration pneumonia. So patients that are intubated, right? We think about patients that are vomiting or just having too much fun, right? And they're just vomiting and they aspirated everything. So that's going to be Fusobacterium aspiration pneumonia. It's usually mixed anaerobes from the oral flora. So once again, alcoholics, think about intubation. So that's going to be the key words for these and how you can kind of pick them up when you're reading the question stem. So diagnosis, usually it's going to be a chest x-ray. You're going to see patchy areas throughout or fluid that's going to be localized to a single lobe. And like we said, consolidation. Usually when we see consolidation, we think about our typical community acquired pneumonias versus things that we see interstitial, or it says interstitial infiltrates. We think about our atypical. And that's usually how I approach a question. I start reading the question. I read and it'll tell you what the patient population is, how old is the patient, what is the risk factors. So once I'm reading that, I read that, right? Alcoholic, I think about current jolly sputum, I think about Klebsiella, right? COPD, think about Haemophilus influenza, a patient that just got better from your influenza in general. I think about what? I think about Staph aureus, right? Most common pneumonia overall for community-acquired pneumonia, Streptococcus, that rust clear sputum. And then I look and see, sometimes they'll give you a description of the chest x-ray, or sometimes they'll just show you a chest x-ray. If it says that there's any type of consolidation going on there, I immediately think about our typical community-acquired pneumonias. I think about Streptococcus pneumonia. If you're reading there, it says that there's interstitial infiltrates, or on your chest x-ray you see interstitial infiltrates, then I think about our atypical community-acquired pneumonias, things like mycoplasma, right? Or your walking pneumonia. So that's how you should kind of address these questions when you are answering them and when you're studying for them. So chest x-ray, like we said, you'll see patchy areas throughout or fluid localized to a single lobe. Consolidation, we think about Streptococcus pneumonia. You're going to do a sputum culture also. For mycoplasma, though, interestingly, you can do a cold agglutinin assay for these patients. And usually for mycoplasma, which is an atypical community-acquired pneumonia, right, we treat with a macrolide. Legionella is another one, which is going to be a atypical, right, atypical bacterial pneumonia. With these patients with Legionella, you diagnose them with a urine antigen, which is pretty interesting, right? And this one's what's very particular about Legionella is going to be that urine antigen. So anything that's specific for these pneumonias, make sure that you know, because that's what they'll test you on. So urine antigens, Legionella. And with these patients, you treat them with doxycycline or a macrolide. So in general, for your community-acquired pneumonias, how are you going to treat them is that if they're outpatient and they're able to go home, they're not looking very sick, right? Usually we think about the curb 65 in regards to whether we need to admit this patient or not. So are they presenting with confusion? Are they presenting with high blood pressure, right? What's the respiratory rate? Are they going to be older than 65? That's kind of what we take into consideration, whether they need to be admitted or not. So usually with outpatient oral macrolides like azithromycin, or you can also give them oral doxycycline. And usually if the patient's an inpatient, then these patients get ceftriaxone and a macrolide like azithromycin, or you can give them a fluoroquinolone like Levaquin. If you are thinking it's pseudomonal, or you just want to cover for Pseudomonas, and you're going to do pip-tazo, right, piperacillin tazobactam. And any patient over the age of 65, like we discussed, if they have cancer, COPD, history of HIV, or asplenia, like they have, for example, sickle cell disease, right, where they auto-infarct their own spleen, or they had some type of injury to their spleen, or they had to get their spleen removed, these patients get admitted. And like we discussed, we think about the curb 65 with these patients, whether these patients get admitted or not, depending on how they present. And remember, just for curb 65, what does it mean? So C is going to be for confusion, right? Your U is going to be for your BRN. Is it going to be greater than 19? R is going to be for the respiratory rate greater than 30, so they're going to be very, very tachypnic. BP is going to be for their blood pressure, so systolic blood pressure less than 90 or diastolic blood pressure less than 60. So I apologize, they're going to be hypotensive. And then their age, they're going to be greater than 65. So that's going to be usually the curb 65 criteria for these patients. So hypotension, I apologize for the blood pressure. So the blood pressure is going to be decreased for your curb 65. So let's go into our atypical bacterial pneumonia. I know I had kind of discussed this one earlier. For atypical pneumonias, we usually think about mycoplasma, right? Legionella, we think about chlamydia, especially like in your younger patients. We think about parainfluenza, also in regards to the viral infections. We think about RSV. So atypical bacterial pneumonias, usually we think about walking pneumonia, right? Usually these patients are fine, they're walking pneumonia. And the most common type of atypical pneumonia is going to be your mycoplasma. So usually this patient population, we're thinking about our younger patients or younger college patients. And then the other one's going to be Legionella. So this one we're thinking about organ transplant, but the very common one's going to be your air conditioner exposure. So they had a dirty air conditioner exposure. Also aerosolized water, air travel. Usually these patients are going to be presenting with symptoms of diarrhea and hyponatremia. That's something that they really like to test you also, is that Legionella is associated with hyponatremia and diarrhea. And usually with these patients, how are they going to present? They're going to have that dry cough versus your community-acquired pneumonia. It's going to be that productive cough. With your atypical bacterial pneumonia, it's going to be that dry cough. And that's how you can kind of differentiate between both of these. These patients are going to be presenting with a low-grade fever, dyspnea, extrapulmonary symptoms like a headache, myalgia, fatigue, and GI disturbance. For your diagnosis, remember in the chest X-ray, we're going to see interstitial infiltrates versus your community-acquired pneumonia. You're going to see those consolidations, especially in your strep pneumonia. And treatment for this is usually going to be with antibiotics like azithromycin. You can give them also tetracycline or fluoroquinolones, but usually azithromycin should suffice. So the next one's going to be your viral pneumonias. Like we said, this is going to be your atypical community-acquired pneumonias or your interstitial pneumonias. The most common one's going to be influenza. Other ones can be RSV, rhinovirus, parainfluenza virus, and even the coronavirus. And with these patients, they're going to be presenting with what type of cough? So it's going to be a dry cough, right? Because we said that majority of atypical pneumonias are going to be dry cough in comparison to your community-acquired pneumonias, which are going to be what types of cough? A productive cough. So for viral pneumonia, they're going to have an insidious onset, dry cough, low-grade fever, wheezing, rhonchi, and crackles. On chest X-ray, you're going to see what? Diffuse infiltrates. Why? Why? Because it's an atypical pneumonia, right? In addition to that, you're going to see usually the infiltrates are going to be concentrated in the perihilar region. And treatment for this is just supportive. Why? Because it's a viral pneumonia. So just ensure that we're monitoring their oxygen, ensuring that the patient does not become hypoxic or hypoxemic, and ensuring that we also give them oxygen if they need it, give them antipyretics to control their fevers, pain medications, ensure that the patient's getting properly hydrated. And then we can just prevent pneumonia in general by doing what? Pneumococcal vaccine, right? Especially in your older patients, and then flu vaccine. Next one's going to be your fungal pneumonias. So these are very, very rare. They're not very common for your fungal pneumonias, but just for exam-wise and for completion, you have different types. So you have blastomycosis, coccidiomycosis, histoplasmosis, cryptococcosis, and aspergillosis. Out of all of these, the baddest of the bad out of all of these is going to be aspergillosis. But let's go into each one. So blastomycosis is usually found in the east of Mississippi. And that's the thing about this one, and how they like to test you is the location. So it's really important that you know the location, and it's going to help you really kind of know what type of fungal pneumonia it is. So blastomycosis is going to be east of the Mississippi, also very commonly found in Central America, and it's usually found in soil and rotten wood, and it's usually transmitted through inhalation. The patient is going to be presenting with fever, night sweats, weight loss, skin and lung granulomas, and we're going to diagnose this with either histology or a culture. Treatment's going to be amphotericin B and itraconazole. So once again, the majority of these fungal infections can be treated with amphotericin B and or itraconazole. So the next one's going to be coccidiomycosis. This one we think about California, southwestern US, and Latin America. Usually the arthrospores are what's going to be inhaled, and it causes a mild lung infection. Usually the patient's going to be asymptomatic. They're going to be presenting with a mild pneumonia, and dissemination leads to bone granulomas or meningitis, and these patients can also present with erythema nodosum. And that's a key for this one, is that erythema nodosum, it's associated with coccidiomycosis. Diagnosis, we're going to do serological testing and imaging. Treatment's going to be amphotericin B and or itraconazole. Histoplasmosis, think about Ohio. How I memorize this one is that it has an H in it. So histoplasmosis, Ohio, and they sound very similar. Another one where it's found is going to be Mississippi. It has that S in it, so that's why I memorize it with Mississippi. Also, it's going to be found in bird or bat droppings in the soil, and the patient inhales it, and it spreads quickly. It causes calcified granulomas, and this patient can either present asymptomatic or they can present with symptoms of mild atypical pneumonia. Usually, it tends to disseminate if a patient has any type of immunocompromised. So usually diagnosis, we're going to see budding yeast within macrophages. On chest X-ray, we're going to see solitary pulmonary calcification, and then our definitive diagnosis is going to be through a sputum culture. Treatment is going to be with amphotericin B and or itraconazole. Cryptococcosis is going to be the next one. This one can be found anywhere in the US, but the thing about this one is that it's found in soil with bird droppings, and that's what's very unique about this one, is going to be that soil with bird droppings, and the humans inhaled the yeast. So the patient can be asymptomatic and can cause pneumonia. This one causes bone or skin granulomas. Dissemination causes cryptococcal meningitis. And usually with these patients, how we're going to diagnose it, we're going to do histology, we'll do a fungal culture, and then we can do a serum cryptococcal antigen and radiology. Treatment is going to be amphotericin B and or fluconazole. Aspergillosis, this one's airborne. What happens with this one is that it causes saprophytic molds, and it causes invasive necrotizing pneumonia, especially in patients that are immunocompromised, like AIDS patients. The molds grow very slowly in the pulmonary cavities, and they produce an aspergilloma, which is really gross. Diagnosis is through a sputum culture or a fungus wall in a chest X-ray or a CT, and this one's really bad. This one usually requires surgery. You have to go in there and get everything out, and then you're going to give them something like either itraconazole or voriconazole. So during my burn rotation, I saw a lot of patients in the burn ICU with aspergillosis, and it kills patients quickly. This one's very deadly, especially when it gets into, the blood circulation. Patients become septic. It's really, really sad. In that case, we'll do something like amphotericin B. All right, guys, so the next one's going to be HIV-related pneumonia. This is going to be an opportunistic infection on a patient with a weak immune system. Usually we think about our patients with HIV, specifically those patients that go into AIDS, so they have a CD4 less than 200, and that's going to be the case for this one. Patients that have a CD4 less than 200, usually it's going to be your patients with AIDS, are very prone to be getting PCP or PJP, right? PJP is the older name, PCP is going to be the new name. So this is very commonly associated with patients with AIDS, and usually any patient that has a CD4 less than 200, we're given prophylactic antibiotics against PCP, and the antibiotic that we give is both the treatment and the prophylactic treatment for the PCP. So the pathogen is usually going to be your Pneumocystis carinii pneumonia, right, or your Pneumocystis jirovecii, which used to be the previous name. So this patient is going to be presenting with a gradual onset fever, dyspnea, dry cough, wheezing, shortness of breath, fatigue, and chest pain. Initial test we're going to do is going to be a sputum culture. We're going to do a chest X-ray, which you're going to see bilateral diffuse infiltrates. And like we discussed, a CD4 count is going to be less than 200. They're going to have an increased lactate dehydrogenase. This is something that you need to know that I've seen on questions some, is that these patients are going to have an increased LDH. But the definitive diagnosis is going to be a bronchoalveolar lavage. Treatment, like we said, it's going to be Bactrim. If the patient is allergic to sulfa, for example, then we can give them dapsone. And then also these patients get steroids like prednisone usually, majority of time, because it causes a lot of inflammation. So let's go into our neoplasms, which is going to be our next one. So something that they really like to quiz you on is on the solitary pulmonary nodule. So it's really important that you know the difference between a benign and a malignant solitary pulmonary nodule. What makes a solitary pulmonary nodule benign, like what characteristics, what's the patient population, and what makes it malignant that you need to further investigate. So a solitary pulmonary nodule is usually going to be a single well-circumscribed nodule that's usually discovered on accident with no associated involvements. Most common benign is going to be usually a patient that's going to be young, so they're going to be younger than 50. They're not going to be smokers. The nodule size is going to be less than 2 centimeters, or I've read some questions that say that it's less than 1 centimeter. It's going to be no growth over 2 years. It's going to be a regular shape. It's going to be circular. and there's going to be central laminated calcification. So this all makes it a benign. If it's a malignant pulmonary nodule, the patient's going to be older, right, greater than 50 years old. They're going to be a smoker, or they're going to have a history of smoking. The size is going to be greater than 3 centimeters. It's going to be having a steady growth. It's going to be irregular in the shape and in the margin. It's going to be stippled, and it'll have an eccentric calcification. So with these patients, right, we want to make sure that we have a differential diagnosis. So knowing the difference between benign hematoma, tuberculosis, or sarcoidosis. Remember, with tuberculosis, usually it's going to be an immigrant. They're going to have a positive PPD. They're going to have fever. And usually the calcification is going to be less than 2 centimeters. Versus things like sarcoidosis, usually with these patients, right, we see bilateral cavitating nodules with hilar lymphadenopathy. If it's a fungal infection, that's a differential diagnosis. Usually these patients are having multiple sizes, and a lot of these patients have like some type of immunocompromise, right? So we want to make sure that the first thing that we do with these patients for diagnostics is that we're going to look for a previous x-ray and compare it. So that's the first thing you're going to do if there's an x-ray available. So compare it to a previous x-ray. If the lesion is stable for more than 2 years, then it's most likely benign, right? If you have a low probability nodule, you're going to do a CT scan. If you have an intermediate nodule, like if it's greater than 1 centimeter, then we're going to do a PET scan. If the PET scan is positive, then we're going to biopsy. If we have a very high probability, like we said, it's very large, it's been changing in sizes, and the patient is a smoker, like they've been smoking for more than 20 years, then with these patients, we're going to biopsy it. So once again, make sure that you know this is something that's very commonly tested in regards to kind of how it's going to present and on who we should do what treatment. All right, guys, so the next one we're going to go into is just going to be your lung cancers, so your bronchogenic lung carcinoma. This is something that's really highly tested, so it's really important that you know the difference between each one, that you know where they present on the chest x-ray and on which patient populations, and how you're going to diagnose each one. This is really what they like to test you on. So for bronchogenic lung cancer, it's divided into 2 groups. So you have small cell lung cancer, and then you have non-small cell lung cancer. Both of these can be fatal, and then they also metastasize very quickly. By far, the most common etiology for bronchogenic lung cancer is usually smoking, 85% of the causes, right? Or they were exposed to secondhand smoke. Or where are they working at, right? Asbestos exposure. So if they have both asbestos exposure and then on top of that they're smoking, that's a double whammy, right? Like we discussed. Radon, COPD, pulmonary fibrosis, history of tuberculosis. This patient is going to be presenting with anorexia, weight loss, night sweats, generalized weakness, cough, dyspnea, hemoptysis, so that bloody cough, chest pain, recurrent pneumonia is another way that the patient can present. So diagnosis is the first thing we're going to do is going to do a chest x-ray. We're going to see that coin lesion or that solitary nodule. Then we're going to do a CT with contrast that's going to help us stage it. We can do a sputum culture and then also a PET scan to see if it's been metastasized anywhere else. But of course, the confirmation is usually going to be with a bronchoscopy and a biopsy. So you have different types of cancer, and that's how I discussed we divide them into small cell lung cancer and then our non-small cell lung cancer. So usually out of the 2, the most common one are going to be your non-small cell lung cancer. About 85% of your bronchogenic cancers are going to be non-small cell lung cancers versus our small cell lung cancers, it's usually about 15%. So they're not as common as your non-small cell lung cancer. So your small cell lung cancers, these spread very, very quickly. And usually by the time you've diagnosed this patient, it's already metastasized, and these have a very high death rate, right? And they have a very low cure rate. And since it metastasizes very quickly, it's not resectable. And that's the key in differentiating small cell lung carcinoma in comparison to non-small cell lung carcinoma. Majority of cancers that are the non-small cell lung carcinomas are resectable versus small cell lung carcinoma. Since it metastasizes so quickly, it's usually not resectable. So you can't treat small cell lung cancers with surgery. So with these patients, it's going to spread really quickly. And like we discussed, it's rarely cured with resection. It's very aggressive and it has a very poor survival prognosis. And where it's going to be located on your chest x-ray is going to be centrally. And how I memorize this is anything that starts with an S is centrally. So small cell lung carcinoma, central, right? We think about also squamous cell carcinoma. It starts with an S, so it's going to be located centrally. Also, another thing how I memorize it is anything that starts with an S is associated with smokers. So S, smokers, S, central, even though central doesn't start with a C. If it helps you, please use it. It definitely helped me on the exams. So smokers, squamous cell carcinoma, central. Smokers, small cell lung carcinoma, central. Okay, so it's going to be located centrally on the x-ray, and that's how you should approach these questions. You're reading the question stem, it's telling you the patient population, the patient's comorbidities, past medical history, smoker. Okay, I'm thinking about either anything that starts with an S, small cell lung carcinoma, or I'm thinking about also the other one, squamous cell carcinoma. I keep reading it. Where is it located? It's centrally located. Okay, that's how you can differentiate between these two. So like we said, it's going to be located central. It's most commonly found in females with a long history of smoking. Another thing we want to think about these is paraneoplastic syndrome. So usually syndrome of inappropriate antidiuretic hormone is associated with small cell carcinoma. This is another thing that they really like to test you is what is associated with small cell lung carcinoma. So SIADH is associated with small cell lung carcinoma, right? This is where you have an increased amount of ADH. You have too much ADH release. The next thing that's going to be associated with small cell lung carcinoma is going to be Cushing syndrome. It's due to ectopic ACTH release. The other one's going to be your Eaton-Lambert syndrome. It's usually due to autoantibodies that destroy the neurons. They cause proximal muscle weakness, decreased deep tendon reflexes, and paresthesias. So diagnosis for these patients, we're going to stage it right. Usually if it's limited, it's usually just confined to the chest. If it's extensive, usually it's going to be outside the chest, or it's metastasized somewhere else. And treatment's really going to be dependent on where it's located. So if it's limited, it's usually going to be with chemotherapy and radiation combination. If it's extensive, then usually these patients get chemotherapy only. Then they get prophylactic radiation. This is going to help prolong their survival rate and decrease the metastasis to the brain, because this is where this cancer really likes to go to. And like we said, surgery is really not beneficial for your small cell lung carcinoma. So just for recap, small cell lung carcinoma, smokers, right? It's located centrally. It's not resectable. Surgery does not work. Now let's go into our non-small cell lung cancer. There's different types. We think about our squamous cell, adenocarcinoma, large cell cancer also that fall under your non-small cell carcinoma. And like we said, this one's going to be the most common one that you're going to see. It's about 85%. And this one is actually cured with resection because this one spreads slower. So they spread slower, it's cured with resection. Usually we can do chemo and radiation in advanced disease. And with these patients, let's go into each one. So squamous cell, we said that it starts with an S, right? Smokers. So this one's going to be centrally located. This one produces keratin, and this one tends to spread directly to the higher lymph nodes. And that's another way you can differentiate squamous versus small cell lung cancer, right? Because they're both located centrally. They're both found in smokers. Is that your squamous cell carcinoma produces keratin. The next one's going to be adenocarcinoma. Out of all the non-small cell carcinomas, this one's going to be the most common type. This one does not start with an S, right? So this one's going to be located actually where? In the peripherals. So it's going to be in the peripheries of the lungs. It's not going to be in the central. It's going to be in the peripheries of the lung for adenocarcinoma. This one forms glandular structures, and it generates mucin or mucus, and it has a low association with smoking. So usually for these, when you're approaching this question stem, it's going to be a woman that's never smoked before, and you've diagnosed this with adenocarcinoma. This one is going to be, the next one's going to be large cell. So large cell, it doesn't start with an S, right? So it's not going to be centrally located. It's going to be where? It's usually going to be peripherally. So it's usually a peripheral lesion, but it can also present in the proximal tissue. It's not very common, so it's not one that you really will see on your exams, but it's still really important that you know. And it has a very late metastasis. It has a poor prognosis. So diagnosis, like we said, we want to stage it via the TNM score, so your tumor-sized lymph node involvement metastasis system, and then also make sure that we get calcium level. Usually these patients are going to have hypercalcemia. Another thing on how to diagnose each one and what they really like to test you on is that anything that is centrally located, right, we can just go do a bronchoscope and then just get a biopsy on it because it's going to be centrally located. Versus your cancers that are peripherally located, like your adenocarcinoma and then your large cell carcinoma. Usually for these patients, since they are peripherally located, what we try to use instead for diagnosis for this is going to be your transthoracic needle biopsy. So make sure that you know this. So approach a question like this, you're reading it. What is the questions them tell you? What is the risk factors this patient has for cancer? For example, non-smoker, right? It's a woman, she's never smoked in her life. You do a chest x-ray, or it describes a chest x-ray that you see nodules that are irregular shaped, right? They're large and they are changing and they're found in the peripheries. So you're thinking about adenocarcinoma. So in adenocarcinoma, we know it's periphery. What's the next thing you're going to do with these patients, aside from the chest x-ray, right, and the CT scan? The next thing I would do for this patient is going to be your transthoracic needle biopsy. Why? Because it's located in the peripheries, right? Okay, let's change this up. Say it's a patient that comes in, they're a smoker, you see that the cancer is centrally located, but you have a differential of diagnosis of either a squamous cell carcinoma or a small cell carcinoma. Why? Because they start with S, right? Centrally located, smokers. So this one, you can actually go in there and do what? You can actually go in there and do a bronchial biopsy. So that's how you are going to differentiate these on what's the next diagnostic test. Is it going to be a transthoracic needle biopsy, or can you go in there and just do go in there and do a bronchoscopy and biopsy, right? Because it's going to be centrally located. And then of course the biopsy is going to tell you which type it is. Is it squamous cell carcinoma or is it your small cell lung cancer? So some of the complications of just lung cancer in general is that the most common areas that it likes to metastasize, remember we discussed the brain, it also likes to go to the bone, the adrenals, the liver, and the lymph nodes. A lot of these patients are going to be presenting with superior vena cava syndrome. It occurs in about 5% of patients. So what happens is that they have an obstruction of the superior vena cava by the tumor where it's growing. So it impairs venous flow to the right atrium. So what's going to occur is that there's going to be venous congestion of the head, the neck, and the upper extremities. So the patient's going to be presenting with that facial fullness, that face and arm edema, dilated veins over the anterior chest, arms and face, and jugular venous distension. Another one complication of lung cancer is going to be your pancreas tumor. This is going to be any type of apical tumor that involves C8, T1, and T1 nerve roots. And what happens is that this causes shoulder pain that radiates down the arm. And this is very commonly associated usually with your squamous cell cancers. Why? Because these are where they are centrally located, right? So this patient is going to be presenting with pain, upper extremity weakness. It's usually associated with Horner syndrome, which is what we're going to discuss next. So what is Horner syndrome? We think about that triad of pupillary constriction, drooping eyelid, right? And then anhidrosis. So Horner syndrome is another one of patients are going to present with a complication of lung cancer, which is going to be due to invasion of the cervical sympathetic chain by an apical tumor. So this patient is going to be presenting with facial anhidrosis, ptosis, and meiosis. And then, of course, if the tumor starts enlarging, it can start compressing on other nerves. So the patient is usually going to be presenting with hoarseness because it's pressing on what nerve? The recurrent laryngeal nerve. The patient can also present with dyspnea and diaphragmatic elevation. Why? Because it's putting pressure on the phrenic nerve. And so prevention just in general for cancer is stop smoking, right? Stop smoking, especially if a patient stops smoking within 5 to 10 years, they can risk their risk of cancer by 50%. And then another thing that they really like to test you on is regards to the USPSTF, so the U.S. Preventative Service Task Force screening. So who do you screen? So you screen with the low-dose CT imaging in patients between the ages of 55 to 74 with either a history of smoking, so if they've smoked more than 30 pack years and continue smoking, or if they've stopped within 15 years. This is something that's very commonly tested, so make sure you know this. Once again, screening with what type of CT imaging? A low-dose CT imaging in who? In patients that are between the ages of 55 to 74 who have either have a history of smoking greater than 30 pack years and continued smoking or have stopped within 15 years. So once again, let's go over all of this because it's very commonly tested. So For cancers, we have small cell lung cancers and then we have non-small cell lung cancers, right? Out of the two, the most common one by far is going to be what type of cancer? It's going to be your non-small cell lung cancers. So for your non-small cell lung cancers, you have what type of cancers? You have your squamous cell carcinoma, adenocarcinoma, and then you have also your large cell cancer. So out of the non-small cell lung cancers, the most common one is going to be adenocarcinoma. Adenocarcinoma does not start with an S, right? So this one is not going to be found in smokers, usually commonly found in women who's going to be a non-smoker, and it doesn't start with an S, so it's going to be peripherally located. The best diagnostic test for these patients is going to be what? A transthoracic needle biopsy. Why? Because it's peripherally located. Next one we're going to go into is going to be which one? Your squamous cell carcinoma. It starts with an S, so it's going to be smokers. It starts with an S, so it's going to be centrally located. Best diagnostic test for this patient is going to be what? It's going to be your biopsy. What type of biopsy for these patients is going to be a bronchoscopy and biopsy. Why? Because it's centrally located. And usually with these patients, surgical resection, right, for non-small cell lung carcinoma can be curative because it doesn't metastasize and it spreads very slowly. Okay, now let's go on to our squamous cell cancers, which are about 50% of the lung cancers. These are starting with an F, so they're going to be what? Small cell lung cancer. They're going to be where? Centrally found in your smokers, and since it's centrally located, you can actually diagnose this with what? You can actually go in there and diagnose them with a bronchoscopy and a biopsy. And these metastasize super quickly. They have a very high mortality rate, and so surgery does not treat these patients. These patients need to have chemo and radiation. So the next one we're going to go into is mesothelioma. This is going to be an aggressive cancer that attacks the mesothelium. And what is a mesothelium? This is what lines the lungs. So it's a cancer of the lining of the lungs, right? Cancer of the lining of the lungs or the pleura. So usually with these patients, it's usually due to asbestos exposure. And that's a key with this one. It's due to asbestos. And this is commonly found in construction materials, insulation, roofing tiles. How is this patient going to present? They're going to have dyspnea, weight loss, cough, bloody effusions, pleural pain, chest pain, shortness of breath, pneumothorax, hemoptysis. And usually with these patients, diagnosis is going to be with a chest x-ray. We're going to do CT scan. That's where you're going to see that pleural thickening, right? Because this is a cancer of what? The pleura. The definitive diagnostic test is going to be with a biopsy of the tumor. You can do immunostain with calretinin, which is going to cause a fried egg shape. And treatment is really going to depend on the stage. We can do surgery, chemo, radiation. Prognosis is poor because a lot of these patients have a few months to survive. So the next one's going to be your pulmonary carcinoid tumor. This is going to be a dysfunction of the neuroendocrine cells that leads to tumor production. It's not very common, but when we do see it, it's very malignant. It's slow and it rarely metastasizes, but when it does, it's very malignant. So this one's found in both like your young population and your older population. So as a bimodal distribution, it's found between patients at age of 15 to 25, and then in the other extremity, 65 to 75. The thing about this one is that there's serotonin synthesis. This is what causes your pellagra or your niacin deficiency. So due to the serotonin synthesis, this is where this patient starts getting all these symptoms, right? So they're going to have these symptoms that are episodic: diarrhea, skin flushing, dyspnea, wheezing. So they're going to have these asthma-like attacks, hemoptysis, recurrent pneumonia, hypotension. But by far the keywords for this one's going to be diarrhea, skin flushing, dyspnea, wheezing. Diagnosis is going to be with the bronchoscopy. You're going to see a pink-purple endobronchial lesion. A CT scan is going to help you localize it. And usually the best test for these patients, though, it's going to be a 24-hour urine with 5-HIAA. So once again, the best diagnostic test for pulmonary carcinoid tumor is going to be a 24-hour urine with 5-HIAA. And you're also going to see, you're going to do serotonin levels, which are going to be very increased. So treatment for these patients, the treatment of choice is going to be surgical excision, right? Just going in there and removing it. You can also give octreotide, usually for symptomatic treatment, since this is going to be a somatostatin analog. But the best treatment and the treatment of choice is just going in there and surgically removing it. So the next one we're going to go to is going to be pleural disorders. So let's start with pleural effusion. This is going to be increased fluid drainage in the pleural space, especially between the viscera and the parietal area. It's going to be increased production of fluid by cells in the space or decreased drainage of fluid. So once again, increased production or decreased drainage. And what happens with these patients is that you have different types of pleural effusions, and this is where they really like to test you. So is it going to be a transudative pleural effusion or is it going to be an exudative pleural effusion? What are some of the causes of each one? So transudative, usually these patients, what happens is that they have too much fluid that leaves the capillaries due to increased pressure. By far the most common one for transudated pleural effusions, and the most common one is going to be what? Congestive heart failure. Other ones are going to be things like cirrhosis, pulmonary embolisms, nephrotic syndrome. So once again, the common one is going to be CHF for transudative pleural effusion. Then you have exudative pleural effusion. So for exudative, I usually think about things that are like bad, gross. So you think about your bacterial infections, right? Your tumors for these patients. So it's going to be an inflammation of the pulmonary capillaries due to leaking fluid, immune cells, proteins, and LDH. So we said bacterial pneumonias, right? A malignancy, tuberculosis, pulmonary embolism, and viral infections. And if you can see, pulmonary embolism falls both in transudative and exudative. So just make sure that you know that. It kept confusing me when I was studying. So this patient's going to usually present asymptomatic, but if they do have symptoms, they're going to have dyspnea on exertion, peripheral edema, orthopnea, which is they feel really bad whenever they lay down. They feel like they're drowning, which makes sense because they have all this fluid. And the keyword for this one is what you're going to see on your physical exam. So on your physical exam, when you do percuss on the lungs, there's going to be dullness to percussion, which makes sense, right? Because there's junk in there. So instead of being hyperresonant, which is where you have those healthy lungs that are full of air, it's going to be the opposite. It's going to be dullness to percussion because you have stuff and junk in there. So dullness to percussion, you're going to have decreased breath sounds, right? Decreased breath sounds, which makes sense because you're going to have a lot of fluid in there, and you're going to have decreased tactile fremitus. So that's when you tell the patient to say E and it sounds like A, and that makes sense once again why, because you have all this junk in there. So dullness to percussion, decreased breath sounds, and decreased tactile fremitus are associated with pleural effusions. On chest x-ray, you're going to see blunting of the costophrenic angle. So blunting of the costophrenic angle, another way I've seen this on exams is literally looks like the meniscus sign. So whenever you have like a cup, right, and you fill it with water, that meniscus sign, and that's how you'll also see it on your chest x-rays. For these patients, you can get lateral decubitus films, which are going to help you, right, because that's where the fluid moves. If it's actually fluid and it's not an abscess or anything solid, then it's going to move whenever the patient moves on their side. CT scans tend to be more reliable. You are also going to do a thoracentesis because this is both diagnostic as well as therapeutic. So it's going to tell you whether it's an exudative or transudative fluid, what's the cause, right? And this is where we use our Leitz criteria. So Leitz criteria is kind of what tells you whether it's transudative or exudative. It's something that they really like to test. So just make sure that you're familiar with it, right? So if it meets any of the criteria, it's going to be exudative. So the things that are measured are going to be your serum protein, your serum LDH, your pleural fluid LDH, and let's go into each one. So transudative, everything's going to be decreased. Everything's going to be decreased. So your protein is going to be less than 0.5, your serum LDH is going to be less than 0.6, and your pleural fluid LDH is going to be less than 2/3 of the upper limit of normal. So everything's going to be decreased once again in transudative, and we said the most common cause is going to be what? Congestive heart failure. Versus exudative, we think about the bad boys, we think about bacteria, bacterial pneumonias, we think about malignancies like tumors, tuberculosis, right? So with these patients, everything's going to be high. So your serum protein is going to be greater than 0.5, your serum LDH is going to be greater than 0.6, your pleural fluid LDH is going to be greater than 2/3 of the upper limit of normal. And if you kind of just think about it in your brain this way, it's going to help you out on your exam on how to ace these. So that is going to be for your pleural effusions. Another thing in regards to the thoracentesis is that on transudative, it's going to be clear, the fluid's going to be clear, or it's going to be straw-colored fluid, versus exudative, which makes sense. It has all this protein, it has all this LDH, it has decreased glucose. You're going to see a cloudy fluid. So treatment's going to depend on whether it's transudative or exudative. If it's a transudative, since the most common cause is congestive heart failure, we want to make sure that we decrease this volume on the patient because the patient's volume overloaded. So given something like diuretics, sodium restriction. We can also do therapeutic thoracentesis or taking out that fluid. Versus exudative, it's usually going to be thoracentesis and then treating whatever its underlying cause. If it's an infection, then we give the patient antibiotics. So the next one's going to be spontaneous pneumothorax. This is where air is normally present in the airless pleural space. So the pleural space is not supposed to have air. Whenever you have air enter that area, this is where you think about your pneumothoraxes, right? So it's usually due to a spontaneous rupture of blebs. It can also be done iatrogenically, so we can cause it by either putting a central line or doing thoracentesis. So the pathophysiology for this is usually what happens is that the bulla breaks, so the air pocket breaks. It causes a hole in the visceral pleura, which causes air to enter the pleural space. And any air that's entering the pleural space, especially in an enclosed area like the chest cavity, is going to cause positive pressure, which is going to cause the lung to collapse, and the lung's going to be unable to expand. So with spontaneous pneumothorax, usually we think about your tall, lean young males, and that's usually how it's going to present on the question stem. So it's either primary or secondary. Primary is going to be that tall, lean young male that's coming in, and all of a sudden they're having like shortness of breath, like acute onset of shortness of breath. Secondary causes is usually due to some type of underlying lung disease like COPD, asthma, cystic fibrosis, TB. And usually secondary causes are more life-threatening than your primary ones. So this patient is going to be presenting with ipsilateral chest pains, which means same-side chest pain. They're going to have a sudden onset, dyspnea, shortness of breath, decreased breath sounds, which makes sense, right? Hyperresonance, and they're going to have decreased or absent tactile fremitus. Once again, these are the key findings for a physical exam, what they like to test you on. Sometimes it'll only provide you these physical exam findings, and you need to tell the difference between a pleural effusion, pneumonia, or pneumothorax, and that's how you can tell the difference. So diagnosis is going to be a chest x-ray. You're going to see absence of lung markings, and with these patients, usually there's going to be a shift towards the same side versus your tension pneumothorax. It's going to be a shift towards the opposite side. Okay, and that's how you can tell the difference between each one, is where is the mediastinum shifting? Is it towards the side? Then we think about spontaneous pneumothorax. If it's away from the side, so it's the opposite to the side, then we're thinking about tension pneumothorax. Treatment, if the patient's asymptomatic, usually we just observe them. We can place a small chest tube. If they're symptomatic, we're going to give them 100% oxygen, and then we're going to do needle aspiration and also a chest tube. And where do these go, right, in regards to the chest tube? They're going to go in the nippoli, anterior mid-axillary, and the fourth and fifth intercostal. Next one's going to be tension pneumothorax. This one is life-threatening. It's a medical emergency. It's accumulation of air in the lungs, and usually that's a one-way valve, right? Air is coming in, but it can't go out. So what happens is that you have increased amount of pressure in that thoracic cavity. It's going to cause the lung to collapse, and it's going to cause that mediastinum to shift away from the lesion. So with these patients, they're going to have decreased pulmonary venous return, so that's going to make the patient hypotensive and tachycardic. Some of the causes of this can be mechanical ventilation, CPR. By far the most common one you're going to see on your exams is going to be any type of trauma to the chest, like gunshot wounds. So this patient is going to be presenting with hypotension, jugular venous distension, so shift of the trachea away from the affected lung is what you're going to see on your chest x-ray. They're going to have decreased breath sounds and hyperresonance on your physical exam. And usually with these patients, diagnosis is clinical, right? If we have a very high suspicion, then we can skip the chest x-ray and just insert that large bore needle, because this is a life-threatening emergency. So treatment, you want to make sure that we immediately decompress it with a large bore needle. Where is this one going to go? It's going to go in the second intercostal, mid-clavicular line, right above the rib margin. And then after you've done that, it's going to be followed by chest tube placement. So let's go into things that affect pulmonary circulation. So pulmonary embolism is going to be the first one. This is going to be a mechanical obstruction of the pulmonary vasculature due to a blood clot, like an emboli. What happens is that the blood flow is obstructed, and the most common cause of a pulmonary embolism is going to be DVT, right? A deep vein thrombosis. Some of the causes of pulmonary embolisms is we usually think about stasis, right? Hypercoagulability. So it's going to be patients that, for example, had a very long car ride. They traveled across the world. So they were on a 12-hour flight, 14-hour flight, trauma to the lower extremity, cancer, pregnancy, oral contraceptives, which makes a patient more prone to becoming hypercoagulable. Recent surgery, usually when we think about recent surgery, we think about our orthopedic surgeries, spine surgeries, right? Hip surgery where the patient is not moving around. And then we also think about Virchow's triad. The mnemonic I have for that is going to be SHE, so S is going to be for stasis, H is going to be for hypercoagulability, and E is going to be for endothelial damage. So any of those things that occurred in the past makes a patient more prone to getting a DVT, which can make a patient more prone to getting pulmonary embolism. So usually when we think about hypercoagulability disorders, right, we think about factor V Leiden deficiency, antiphospholipid syndrome, lupus also, right? So this patient is going to be presenting with an acute onset of dyspnea, so trouble breathing, pleuritic chest pain, cough, hemoptysis, syncope. They can also present with cardiogenic shock, tachypnea, rales, tachycardia. This patient can also present in obstructive shock. On physical exam, you're going to hear an S4. You'll also see dullness to percussion, decreased breath sounds. And if the patient has a pulmonary saddle, that's where the clot gets stuck in an area that can obstruct completely the air to the lungs, then these patients usually have sudden death. So the diagnostic test, the initial test we're going to do is going to be a CT scan. The most accurate one, though, is going to be a pulmonary angiography. On chest x-ray, what we're going to see is going to be that Hampton's hump, and that's what they really like to test you on. So it's that pleural wedge, and then you'll see a Westermarck sign also, which is going to be that vascular cutoff. If you have a low suspicion of pulmonary embolism, then you can do a D-dimer. If it's negative, then you can rule out pulmonary embolism. If it's increased, then usually with these patients, we're going to do further testing. If the patient, for example, is pregnant or for some reason they can't do a CT scan, then we can do something like a ventilation perfusion scan or a VQ scan. And usually it's going to show us a ventilation perfusion mismatch. So it's going to be any type of patient that has any allergies to contrast, right? If they're pregnant, if they have chronic kidney disease. We can also do an ABG. You're going to see respiratory alkalosis. Why? Because they're hyperventilating. They're really trying to get air in. They're going to have decreased oxygen saturation. You can also do the PERC score and the Wells criteria just to rule out a pulmonary embolism. So treatment for these patients, the first thing we're going to do is we're going to give them heparin, right? Usually we can do something like low molecular heparin, especially in a stable patient. If they have renal failure, then we're going to do unfractionated heparin. We're also going to give them oxygen. If the patient has severe hypoxemia, then we can intubate them. We might even have to mechanically ventilate them. Give them fluids, especially if they're hypotensive or pressors. Now, once a patient has had a pulmonary embolism and it's been treated, they need to be put on long-term anticoagulation. So usually they're on anticoagulation for about 3 to 6 months, and our drug of choice is usually going to be warfarin. Warfarin, why? It's, I know you have a lot of those new anti-thrombotic medications or antiplatelet medications, but warfarin's cheap. So oral warfarin, usually what we're going to give, and we want to make sure that we're monitoring that INR. We want to target the INR between 2 to 3. So with these patients, another thing that we can give them is like rivaroxaban or apixaban, right? Your anti-10A inhibitors. And for example, our last resort though for these patients is going to be a pulmonary embolectomy. We can also do that if, for example, a patient has a contraindication for antithrombotics. Then, for example, if they had a previous cranial bleed or etc., then in these patients we can do a pulmonary embolectomy or an inferior vena cava filter, right? That's especially, like we said, if anticoagulation is contraindicated. So the next one's going to be pulmonary hypertension. This is usually when the pulmonary arterial pressure is greater than 25 millimeters at mercury at rest and greater than 30 during exercise. What happens is that the right ventricle hypertrophies. And usually with these patients that have pulmonary venous system resistance, there's a left to right shunt. It's usually due also in regards to the left to right shunts. We think about atrial septal defect or patent ductus arteriosus, pulmonary embolism, pulmonary stenosis, chronic hypoxemia, COPD, and obstructive sleep apnea that can cause pulmonary hypertension. And it's usually classified according to the WHO classifications. So group 1 is pulmonary arterial hypertension. Usually it's going to be The causes are usually going to be idiopathic due to lupus, HIV. Then we have group 2. This is pulmonary hypertension due to left heart disease. This is usually due to left heart failure, valvular heart disease, or right to left shunt. Group 3 is pulmonary hypertension due to chronic lung disease and or hypoxemia. So we think about COPD, obstructive sleep apnea, right? Chronic hypoxemia. Group 4 is going to be pulmonary hypertension due to chronic thromboembolics. So it's going to be a patient that has recurrent pulmonary embolisms. And then group 5 is going to be pulmonary hypertension due to unclear mechanisms. So how is this patient going to present? They're going to be presenting with dyspnea on exertion, fatigue, chest pain on exertion, syncope on exertion, loud P2. They'll have a subdural lift. Why? Because there's going to be a right ventricular dilation. They can also present with right tricuspid regurgitation, so they're going to have hollow systolic murmur. Diagnosis, the best initial diagnosis for these patients is going to be an echocardiogram, and that's where you're going to see a dilated pulmonary artery. You'll see hypertrophy or dilation of the right atrium and right ventricle, and you're going to see abnormal movement of the IV septum. So, another thing that you can do for these patients is a chest x-ray. You're going to see enlarged pulmonary arteries. On EKG, you're going to see right ventricular hypertrophy, so there's going to be that right axis deviation, right? On spirometry is another thing you can do, and this is going to help you find what is the underlying disease that is causing your pulmonary hypertension. Gold standard, though, diagnostic for pulmonary hypertension is going to be a right heart cath. And this is where we're going to see increased pulmonary arterial pressure that's going to be greater than 25 millimeters of mercury. So treatment for this is treating whatever is causing the pulmonary hypertension. We can also give them vasoactive agents, oxygen, diuretics. That's going to help decrease the edema. Digoxin, right, is going to help that contraction of that heart. But usually these patients need a lung transplant. Next one's going to be cor pulmonale. This is going to be pulmonary hypertension that leads to structural changes to the right ventricle, which causes the right ventricle to become either dilated or hypertrophied. It's usually due to an underlying pulmonary disorder. So what happens with the pathophysiology is that there's an increase in pulmonary pressure that leads to an increased right ventricular afterload. So the pressure causes the expulsion of blood, which leads to right ventricular dilation, and hypertrophy, which leads to right heart failure or arrhythmias, which leads to death. So the most common form of cor pulmonale is chronic, and it's usually due to COPD, but it can be due to multiple things like cystic fibrosis, interstitial lung disease, bronchiectasis, obstructive sleep apnea is another one. Usually acute cor pulmonale is usually due to something like pulmonary embolism. This patient's going to be presenting sometimes asymptomatic, but if they do have symptoms, they're going to have decreased exercise tolerance, dyspnea on exertion, parasternal lift, loud S2, clubbing. Remember when we discussed any form of clubbing is a sign of hypoxia or hypoxemia. They're going to have symptoms of right heart failure, so it's going to be that edema, right? Hepatosplenomegaly, jugular venous distension, tricuspid regurgitation. In diagnosis, the initial test is going to be an echocardiogram. We're going to see that right ventricular dilation, but our confirmatory test is going to be a right heart cath. And EKG is another one that we can do. We're going to see that right atrial deviation, right ventricular hypertrophy. We can also do a chest x-ray. We're going to see enlargement of the pulmonary arteries and prominent right heart border. And treatment is just treating the underlying disorder. What is causing it? So if it's COPD, bronchodilators, inhaled steroids. If it's obstructive sleep apnea, CPAP. If it's congestive heart failure, diuretics. Exercise, oxygen, and then you can also give things like calcium channel blockers. So the next one's going to be restrictive pulmonary disorders. I know we went over obstructive, so let's go over restrictive. And then remember with restrictive, there's a problem getting air in. So the patient cannot get air in, but they can get air out. Versus obstructive, they have no problem getting air into the lungs. It's a problem getting air out. The first one we're going to go over is going to be idiopathic pulmonary fibrosis. And this is a restrictive interstitial lung disease due to increased collagen, so fibroblast activation, or scar tissue in the lungs. So what happens is that there's thickening in the lungs, and that causes poor ventilation. The most common cause is, it's the most common cause of interstitial lung disease. It's progressive and chronic, and some of the risk factors are going to be an older patient, 60s to 70s, males, smokers, and then chronic aspiration. And so usually patients that get GERD also, which I thought was really interesting, are very prone to getting idiopathic pulmonary fibrosis because they're constantly aspirating that stomach acid into the lungs, which is damaging the lungs. So this patient is going to be presenting with a gradual onset of non-productive cough. They're going to have dyspnea on exertion by basilar crackles. They're going to have these dry and inspiratory Velcro-like crackles, and that's usually the key for this one, is those Velcro-like crackles. They're going to be cyanotic and clubbing. Remember, whenever we think about clubbing, it's very chronic. It's usually patients hypoxic or hypoxemic. The key for this one is going to be your diagnosis and what you're going to see on the chest x-ray. So on the chest x-ray, you're going to see that honeycombing pattern, and that's the key for idiopathic pulmonary fibrosis. And this is usually a loss of alveoli. You're also going to see reticular opacities or fibrosis. You can also do a CT scan or a high-resolution CT scan. You're going to see subpleural cystic changes and traction bronchiectasis. You can also do a spirometry or pulmonary function test, and it's going to give you a restrictive pattern, right? Why? Because it's a restrictive pulmonary disorder. There's going to be decreased total lung capacity. Why? Because you're not able to get air in, right? So you're not going to be air trapping like obstructive pulmonary disease. So the lungs are holding less air. There's going to be decreased forced vital capacity, decreased forced expirational volume, FEV1. But the diagnosis for idiopathic pulmonary fibrosis is going to involve surgical lung biopsy. So usually treatment for these patients, it's really supportive. If anything, there's nothing really that we can give them that is going to alter the course of the destruction of the lung. So we're going to give them oxygen. If it's acute, we can give them something like IV steroids, pirfenidone, and nintedanib. Usually the patients have a mean survival of 3 to 7 years after they've been diagnosed, but the definitive treatment is going to be a lung transplant. This is going to help with survival and the quality of life of the patient. So once again, idiopathic pulmonary fibrosis, think about that honeycombing on your chest x-ray. Next one's going to be pneumoconiosis. There's different types of miniconiosis. This is something that's very commonly tested, so it's really important that you know. So why don't we go into each one? And like we discussed, this is going to be a type of restrictive pulmonary disorder. And what happens is that there's toxins that recruit macrophages. They release chemokines like IL-1 and IL-8, and these damage the alveolar epithelium. They cause fibroblasts, which increases collagen. So you have co-workers pneumoconiosis, there's asbestosis, silicosis, borreliosis, and byciniosis. So the key for these is knowing what patient population they're going to present in and how they're going to present on the chest x-ray. That's the key and how you can differentiate these. If you understand that and you know this, you'll be able to differentiate them very well. So co-workers pneumoconiosis, how it sounds, co-workers, it's due to coal mining. It's going to be found in your coal miners. What happens is that they have this constant inhalation of the coal dust, and they have increased carbon or silica over many years. So this patient is going to be presenting with cough, dyspnea, and shortness of breath, rales, and rhonchi. The initial diagnostic test is going to be a chest x-ray. You're going to see these small apical opacities, usually commonly found in the upper lobes. So remember how I was discussing that it's really important to know where these present. So these are going to be on the upper lobe. So treatment for these patients, we just want to make sure that we minimize exposure, right? Educate the patient on protecting themselves and make sure that we vaccinate them. So vaccinate them against the flu and the pneumococcal vaccine. Next one's going to be asbestosis. This one's very commonly tested, so you have to make sure you know this one. This is going to be an inhalation of those asbestos fibers, so old homes, insulation, construction, and this one's going to be found on the lower lobes. So once again, lower lobes. And usually these patients are going to have about 15 to 20 years of exposure, and it's going to be found where? On the lower lobes. This patient is going to be presenting with dyspnea, dry cough, chronic chest pain, fine rales, finger clubbing, pursed lip breathing. It's usually going to be those shipyard workers or construction workers. Initial diagnostic test is going to be a chest x-ray. This is where you're going to see those hazy infiltrates with bilateral linear opacities. And you're going to see these calcified pleural plaques at the lung bases, right? Lower lobes, once again. But the most accurate diagnostic test is going to be a biopsy. There's no treatment for these patients. Usually it's palliative, and this one's associated with non-small cell lung cancer, right? And malignant mesothelioma, and that's going to be the malignant risk. That's another thing that they really like to ask is asbestos, mesothelioma, and non-small cell lung cancer. Next one's going to be silicosis. So this is going to be rock mining, stone cutting, quarrying, sand blasting. That's the one I commonly see is going to be sand blasting, sand blasting, sand blasting. Glass manufacturing. Etiology, usually acute, is going to be any patient that had any type of massive exposure. And usually these patients have a rapid onset of silicosis and they can die very quickly. But of course, the common one we're going to see on your exams is going to be a chronic. So it's going to be a patient that's been exposed repeatedly, more than 15 years, so they start having these symptoms years after they've been exposed. So they're going to be presenting with dyspnea and exertion, cough with sputum, rhonchi, rales, wheezing, tachypnea. The best initial test is going to be a chest x-ray. We're going to see a localized nodule in the upper lung lobes. So once again, upper lung lobes, right? And what you're going to see is eggshell calcification of the hilar node. So once again, this is the key word for this one. How I memorize it, it has an S, right? Silicosis, eggshell calcification. Treatment is removal of exposure to silica. All these patients need a tuberculosis test also because they have a very high risk of tuberculosis. And they also need to make sure that they are vaccinated against the flu and the pneumococcal vaccine also. Also educate these patients to stop smoking because if they smoke and then on top of that, they also are being exposed to all these things, they have a very high risk for cancer. Next one's going to be berylliosis. Usually with these patients, it's usually due to exposure to beryllium, so they can present with granulomas, skin lesions, and hypercalcemia. And this one's located where? On the upper lobe. Diagnosis is going to be a blood test. You're going to see the beryllium lymphocyte proliferation and transformation tests. We think about usually our aerospace, and that's a key for this one, and how you're going to see it on exams is aerospace, dental, computers, fluorescent bulbs. Treatment's going to be with glucocorticoid therapy for both acute and chronic. Next one's going to be byssinosis. This one's due to cotton dust, production of yarns, and rope making. Usually these patients are going to have a lot of exposure, also commonly found in your smokers. They're going to be presenting with asthma-like symptoms, especially the early symptoms, the late symptoms. Usually they're going to have tightness, chest tightness at the end of the day. And this is where you think about the Monday chest tightness, right? Because they're better on the weekend, and then once they start working on Monday and they start getting re-exposed to this, they start feeling bad again. So look for that in the question stem. Diagnosis is going to be routine spirometry, PFTs, right? And treatments just exhaust hoods, right? Avoiding whatever is causing this. So once again, make sure you know these asbestosis, right? We said the lower lobes, shipyard workers, and construction. This one's associated with mesothelioma and non-small cell lung cancer. We think about silicosis for your rock miners, sand blasting. This one's going to be found in the upper lobes. It starts with an S, so silicosis, eggshell calcification. These patients need a TB test because they're at risk for getting tuberculosis. Berylliosis, we think about aerospace, right? This one's found in the upper lobes. And byssinosis, we think about cotton dust. This one's going to be presenting with that Monday chest tightness that they go back to work on Monday and they start having these symptoms again, but they feel better on the weekends. Next one's going to be sarcoidosis. This is due to non-caseating granulomas that occur in the lungs, the skin, the eyes, the peripheral nerves, liver, kidney, and heart. The cause is idiopathic. It's very commonly found in your African American woman, younger in the ages between 20 to 30. And that's how it's going to present on your question stem. They're going to be presenting with dyspnea, shortness of breath, chest pain, malaise, fever, weight loss. Lupus pernio is another one. So they're going to have that chronic rolaceous raised plaque or nodules on the face, uveitis, arthralgias, erythema nodosum, and neuropathies. Initial diagnostic test for these patients is going to be a chest x-ray. And that's a key for this one is going to be those non-caseating granulomas and bilateral central lymphadenopathy. Once again, non-caseating granulomas and bilateral hilar central lymphadenopathy. On labs, you're going to see hypercalcemia, and you're going to see elevated ACE levels, or your angiotensin converting enzyme levels are going to be very, very high. That's another key for this one that they really like to test. but the most accurate test is going to be a biopsy, and that's where you're going to see, once again, those non-casein granulomas. If you do a bronchial alveolar lavage, you're going to see an increased CD4 cells. So usually with sarcoidosis, they tend to go by themselves, but if you do need to give them treatment, you can give them prednisone. If it's refractory, then you can do something like methotrexate. But usually these patients get an annual EKG, PFTs, and ophthalmology exams because, like I said, it's associated with occurring anywhere in the skin, the eyes, the liver, the kidney, and the heart with these non-casein granulomas. So the next one we're going to go into is going to be sleep apnea, or your hypoventilation syndrome. So we think about obstructive sleep apnea, right? This is usually stopping breathing. So patient that stops breathing at night due to obstruction. They have irregular breathing and snoring patterns, and it's apnea due to blockage of airways at night. So usually in the question stem, it's going to be obese man that presents, and the wife is bringing them in because the patient snores really loud. And it's usually the wife that brings them in because the patient is just very tired throughout the day. They feel like they're not sleeping good throughout the night, and they snore really, really loud, and they're obese. So the etiology is going to be supine sleeping, REM sleep. Most commonly, it tends to be most commonly compared to central apnea. And risk factors, like we said, obesity. Why? Because the increased BMI increases that neck size, so it increases that pressure on your airway. More commonly found in males. Also, any type of nasal obstruction can cause obstructive sleep apnea. So we think about allergic rhinitis, especially if they have those enlarged polyps in the nose, which is decreasing that airflow with these patients. Also, they'll have a family history, and usually the age is going to be between 50 to 59. So this patient is going to be presenting with excessive daytime sleepiness, like I discussed, severe exhaustion. So no matter how much they sleep, they still feel really tired throughout the day. Severe sleep deprivation, nocturia, insomnia, difficulty concentrating during the day. Also, headache is another one. So if a patient wakes up with constant headaches and they're obese, think about obstructive sleep apnea. Fatigue, snoring, nocturnal choking or gasping, nocturnal angina, morning headaches, and usually they'll have either enlarged tonsils or a very large neck size. So diagnosis, we're going to do a sleep study. This is where we look at the episodes of apnea. And treatment's going to be CPAP, so your continuous positive airway pressure. You also educate the patient to lose weight, right? Avoid alcohol, sleep on their side. But CPAP is going to be really important for these patients. And there's a lot of things that are associated with obstructive sleep apnea, like we discussed, right? Congestive heart failure. So it's really important that we treat these patients. The next one's going to be central sleep apnea. This is periods of absent breathing during sleep due to central nervous system mediated apnea. So this is going to be more up here. It's not going to be a type of obstructive like obstructive sleep apnea. This is going to be more up here. It's some type of neurological malfunction for central sleep apnea. So some of the etiologies is going to be obesity, once again, more commonly found in males. If they have any type of nasal obstruction, also if they have a family history, and then the age 50 to 59. They're going to be complaining of poor sleep, severe sleep deprivation, nocturia, insomnia, difficulty concentrating during the day, headache, fatigue, and snoring. Diagnosis is going to be your once again your sleep study, and treatment for this is going to be CPAP. And then also avoiding alcohol, sleeping on their side rather than their back. Next one's going to be obesity hypoventilation syndrome, also known as Pickwickian syndrome. They have a really cool episode on House in regards to this. So this is usually hypoventilation in overweight patients. And what happens is that it lowers their oxygen levels, and these patients have higher CO2 levels, so they're retaining a lot of carbon dioxide, so they're going to be hypercapnic. Some of the etiologies are going to be obesity, so high BMI greater than 30, where the body cannot compensate for the stress of the extra weight that is being placed on the body. So the patient is going to be an overweight or obese patient. They're going to be complaining of daytime sleepiness, fatigue, shortness of breath. They're going to have lower limb swelling, hypersomnolence, and they're going to be snoring very loud. So usually with diagnosis, we're going to measure their CO2, which is going to be greater than 45. Their BMI is going to be greater than 30. We're also going to do a sleep study. And the thing about obstructive hypoventilation syndrome, it's usually a diagnosis of exclusion. So once you've excluded obstructive sleep apnea and central sleep apnea, then you can diagnose these patients with obesity hypoventilation syndrome. Treatment for these patients is going to be weight loss. Remember, we discussed anything that's conservative is going to be first line unless the PANCE specifically asks you what is the best treatment, etc. So weight loss, diet and exercise, CPAP. If it's severe, then you can do tracheostomy or bariatric surgery, and just educating the patient, right? Losing weight. Some of the complications of all of these, like we discussed, congestive heart failure, right-sided heart failure, pulmonary hypertension. So let's go into other pulmonary disorders. So acute respiratory distress, something that we've seen a lot in our COVID-19 patients. This is usually due to sudden respiratory failure following systemic or pulmonary insult that causes hypoxia and hypercapnia. So hypoxia, decreased oxygen. It's due to an underlying condition. This is what happens is that there's neutrophil activation in systemic or pulmonary circulation, which causes massive intrapulmonary shunting of the blood, which leads to severe hypoxemia and pulmonary edema. There's going to be widespread atelectasis, collapse of the alveoli, and surfactant dysfunction. The risk factors by far, the most common one's going to be sepsis. So we think about infections like pneumonias, COVID-19, right? Urosepsis, wounds, aspirations, trauma, fractures, pancreatitis, drowning, opioid overdose. How is this patient going to present? They're going to have dyspnea, tachypnea, tachycardia. So you're going to see those retractions, crackles, rales, anxiety, agitation. The patient won't be able to speak. They're going to be cyanotic. They're going to have impaired mentation. Why? Because they're holding on to all this carbon dioxide. So diagnosis, we're going to start with the chest x-ray. We're going to see bilateral infiltrates, CT scan. That's where you're going to see your ground glass appearance. You're going to do a pulmonary artery catheter. Usually the pulmonary artery catheter wedge pressure normal is going to be less than 18. Anything greater than that is really bad. With these patients, treatment is just making sure that we get the patient to oxygenate. So our goal oxygenation is going to be greater than 90%. We're going to intubate them, right? PEEP. So we're going to put these patients on a low tidal volume fluid management, make sure that we avoid any type of volume overload, and then treat whatever is the underlying cause. So cystic fibrosis is going to be the next one. This is going to be a genetic condition. What happens in these patients is that they have a thick, viscous secretion in their respiratory tract, their pancreas, their sweat glands, their intestines, and their GU tract. And why do they have this? It's because they have an autosomal recessive problem. So it's due to the CFTR gene on chromosome 7. And this one's important in movement of salt and water across cell membranes. So very commonly found in your Caucasians, right? It's an obstructive disease, and it's the most common cause of bronchiectasis. So these patients are going to be presenting with fatigue, chronic productive cough, recurrent or chronic upper respiratory infections. They're going to have this thick, sticky mucus. They're going to be complaining of digital clubbing. They're going to have a barrel chest, chronic hypoxia, nasal polyps, abdominal distension, rectal prolapse. The key for this one is going to be that steatorrhea, right? And those chronic and recent upper respiratory infections. So steatorrhea is going to be those fatty, stinky stools. Why? Because they're malabsorbing. Usually in your newborns, you're going to see meconium ileus also. These patients are going to have failure to thrive, and they're going to have vitamin A, D, E, and K deficiency, right? They can also have peripheral edema. Why? Because they're going to have malabsorption of proteins, and they're going to be insulin deficient. Why? Because it tends to involve the pancreas. So with these patients, we usually look for that during a newborn screen, but if we diagnose an older patient, the best way to diagnose them is going to be a sweat chloride test. And usually it's going to be positive, so they're going to have high sweat sodium and chloride levels. We're also going to look at their digestive enzyme, which are going to be decreased. And treatment is just pancreatic enzyme replacement, right? Because these patients are missing that enzyme. So pancreatic enzyme replacement, we're also going to give them fat-soluble vitamin supplements like A, D, E, and K. Educate the patient on their diet, so increase the amount of calories and protein that they are having in their diet. Chest physical therapy is really helpful in these patients, right? Those breathing exercises, We also are going to give patients antibiotics for infections because these patients are very prone to getting pseudomonal infections. And then in regards to the complications is that they can have respiratory and GI complications. A lot of these patients are infertile. And like I said, the most common pathogen bacterial infection that causes this repetitive upper respiratory infections is going to be Pseudomonas, which is your gram-negative bacteria. So next one's going to be bronchiectasis. This can be either congenital or acquired. So with bronchiectasis, what happens is that there's a dilation and compensation of the large bronchi due to chronic inflammation, and it's an obstructive type of disorder. What happens is that there's a permanent abnormal dilation or destruction of the bronchial walls due to chronic inflammation, the airways collapse, and then there's ciliary loss and dysfunction, leading to impaired clearance of secretions. So the patient isn't able to clear those secretions. So remember that when we discuss anything that causes stasis is a great area for bacteria to replicate and to reproduce. So what happens is that there's a destruction of elastin and cartilage, which causes dilation and weakening of the walls. The most common cause is going to be cystic fibrosis by far, but there can be other causes like recurrent infections. We usually think about Cardigan syndrome, and I apologize if I missaid that. This is usually due to a primary ciliary dyskinesia. It's also associated with rheumatoid arthritis, lupus, and Crohn's disease. So this patient's going to be presenting with a chronic cough with large amounts of mucopurulent, foul-smelling sputum. And that's the key for this one. It's going to be that foul-smelling sputum cough with like these large amounts of like smelly sputum. This patient's going to be presenting with dyspnea, hemoptysis, recurrent pneumonias, and treatment and diagnosis for these patients is usually going to be chest CT, and that's actually the best initial and most accurate diagnostic test is going to be a high-resolution chest CT. We can do a PFT also. We're going to see an obstructive pattern. Chest x-ray, usually normal. It's not very specific. If we do a chest x-ray, we might see some tram tracking also. So treatment for these patients is usually going to be with prophylactic antibiotics, so things like amoxicillin, azithromycin, Bactrim, ciprofloxacin. We can also do pip/tazo to cover for Pseudomonas and Mycoplasma. Bronchial hygiene, right? Hydration, chest physiotherapy, pulmonary toilet, like those incentive spirometries, beta agonists, bronchodilators, and mucolytics, which is going to help like break down all that mucus, and just educating the patient. Stop smoking if they're smokers, right? It's going to worsen that. Vaccinate them against pneumococcal and flu vaccine. So the next one's going to be your foreign body. So usually a foreign body is going to be a placement of a foreign body in either the trachea or the bronchi, most commonly found in children, but of course you can also find this in adults, especially if they have any type of neurological problem, right? Or sometimes they do it intentionally. So some of the common things you're going to find is either organic or inorganic items. So when we think about inorganic, we think about toys, coins, pins, and clips. Organic, we think about food like nuts, right? And it's most commonly going to lodge in the right bronchus. Why? Because just of the anatomy and how it's just a straight shot. So that's something that they really like to test. So right bronchus, it's going to be where it's commonly located. So like I said, the right lung via the right bronchus is going to be the most common one, but it can get stuck anywhere else, like in the left lung, the trachea, the carina, the larynx, bilateral. But by far the most common one is going to be that right lung, that right bronchus. So this patient is going to be presenting with sudden respiratory distress, choking, cyanosis, mental status. And the key for this one is telling the difference between it's a partial obstruction or a complete obstruction. A complete obstruction, this is an emergency. These patients can die. So partial obstruction, usually this patient is going to be presenting with coughing, gagging, wheezing, drooling, diminished breath sounds, tachypnea, stridor, and dyspnea. Versus complete obstruction, this is a medical emergency. They're going to have stridor, wheezing, dyspnea, hoarseness, and this patient's going to be in acute distress. Diagnosis is going to be a chest x-ray. You can also do a chest CT, especially if the x-ray comes back negative. And what we're going to see on the chest x-ray is that the obstructive lung is going to be more hypodense. Why? Because the air is going to be unable to exit the lung. And another thing that we can do is for diagnosis is going to be a rigid bronchoscopy. This is both diagnostic and therapeutic, and this is actually the gold standard because it's going to help you also remove the foreign body. Next one's going to be your hyaline membrane disease. It's also known as your infant respiratory distress syndrome. Usually what happens with these patients is that they have trouble breathing because they're lacking surfactant. Remember, surfactant is what kind of coats the lungs. That helps decrease that friction. It helps that sliding. So if a baby's not having that, then they're going to have problems. So it's due to deficiency of surfactant. It leads to increased surface tension in the alveoli, so the patient's going to have difficulty inflating their alveolar units. So the alveoli are going to collapse, and it's going to result in progressive and diffuse atelectasis, decreased lung compliance, like I discussed. Very commonly found in your preemie babies, right? Your premature infants. Because what happens is that surfactant is usually produced by 33 to 36 weeks, and it tends to surge after 36 weeks. And so if a patient is born before that, then they're not going to produce the surfactant. So they're going to be presenting with tachypnea, labored breathing, cyanosis, grunting, nasal flaring, retractions of the intercostal and subcostal muscles. They'll have respiratory difficulty within a few hours of birth. So diagnosis, we can do a chest x-ray. You're going to see that diffuse ground glass appearance and decreased lung volumes. You can do an ABG, a pulse ox, and treatment's just ensuring that we do antenatal corticosteroids for mommy, right? So that's why if a mom is going to go into, they have premature rupture of membranes, right? Preterm premature rupture of membranes, PPROM, these patients, and they need to go into labor because they have eclampsia or trauma or something else, right? Then these patients, we have to make sure that we give the mommy steroids. That's going to help the baby develop their lungs and avoid things like hyaline membrane disease. So if the baby is born with hyaline membrane disease, then we're going to give him nasal CPAP, intubate him, right? And then we'll have to give him exogenous surfactant therapy with an ET tube. So let's go real quick in regards to pharmacotherapeutics. This is something that's really commonly tested, so we have to make sure that we are familiar with pharmacotherapeutics. So let's go into each one. So inhaled steroids, we think about memetazone, right, fluticasone, budesonide, and beclomethasone and triamcinolone. Mode of actions is that they inactivate your NF-κB, the factor that produces your TNF alpha and other inflammatory agents. So they're anti-inflammatory. It's used for chronic asthma, COPD. Some of the adverse effects, like we discussed, remember that we educate these patients to brush their teeth after they use it because they have very high incidence of associated with thrush. So topical candidiasis. So just make sure that you educate the patient to wash their mouth, rinse their mouths after they use it, and you treat this with nystatin. Next one's going to be your beta-2 agonists, right? We have short-acting and we have long-acting. The mechanism of action is that they increase CAMP, so they increase smooth muscle relaxation, so they improve that airflow. They cause vasodilation of the blood vessels. They can also cause tachycardia, and they bronchodilate. They're used for asthma, COPD, bronchospasms from chemical irritation, and they can also be used for hyperkalemia. So remember, in regard to our treatment for hyperkalemia, our treatment usually for these patients, of course, remember we want to stabilize that cardiac membrane. So first what we're going to do is that we'll give them calcium, right? And then after that, we can do things like insulin, which is going to help move that potassium into the cell. And then the other thing that we're going to do is we can give them something like a beta agonist, like albuterol. So that's another mechanism of action of how you can use beta agonists, hyperkalemia. Some of the adverse effects are going to be tachycardia, hypokalemia, like we discussed, anxiety. And there's different types. There's short-acting beta agonists and long-acting beta agonists. Usually with SABAs, it's usually going to be for acute exacerbations of asthma. And like I said, everyone gets a SABA for asthmas. So we think about albuterol, levoalbuterol, and terbutaline. Terbutaline is the one that's usually associated with pregnancy, that we use in pregnancies, right, when a woman's about to go into labor. We think about LABAs, which are going to be long-acting beta agonists. This is usually used for maintenance or prophylaxis, right? And we think about salmeterol and formoterol. Now let's go into our muscarinic antagonists. These block muscarinic receptors. They allow for bronchodilation. So we think about ipratropium or tiotropium. These are going to be long-acting. They're used for asthma exacerbations in combination with a SABA. They're also used for COPD. Some of the adverse effects are going to be paradoxical bronchospasm and angle closure glaucoma and bronchitis. Next ones are going to be methylxanthines. These cause bronchodilation via inhibition of PDE3. and they also cause anti-inflammation via inhibition of PDE4. And we think about these as oral theophylline or IV aminophylline. With these, some of the adverse effects is that they can cause seizures, coarse tremors, headaches, nausea and vomiting, abdominal pain, arrhythmias, hypokalemia, and hyperglycemia. Next one's going to be your cromolyn. This is a mast cell stabilizer. It prevents degranulation of inflammatory mediators. It's used for asthma. It can be either inhaled or nebulized. And this is usually used for prophylactic use. It's given about 10 to 15 minutes before a known trigger like exercise, cold, air, or animals. The adverse effects are transient cough or burning or itchiness sensation of the nose, especially if a patient uses it inhaled. So the other one's going to be anti-leukotrienes. Just like the name of this class of drugs is that they decrease the synthesis of leukotrienes. We think about meclofenamate and xyluten. What they do is that they antagonize leukotriene receptors. We also think about montelukast or Singular, right? They're used for chronic asthma, aspirin-induced asthma, exercise-induced bronchospasm, COPD, and allergic rhinitis. Adverse effects is suicidality. And then we have omalizumab. This is a monoclonal antibody against IgE. It binds and inhibits free-storm IgE. And IgE is usually involved in bronchoconstriction, so that's why we use this one. It's used for moderate to severe asthma, chronic idiopathic urticaria, and it's also used for patients that have asthma due to allergies. So any type of allergic asthma, omalizumab is really good for this. Adverse effects is hypersensitivity reaction and serum sickness reaction. These are very expensive, so we tend to not really prescribe these. Alright guys, so that was it. If I have any mistakes or anything like that, please comment below, or if you have any cool mnemonics, like I said at the beginning of this video, for other students to use in regards to memorizing certain medications, like for example, the bribe therapy, right, for tuberculosis, which is something that's very commonly tested. If you have cool mnemonics for that, if you have cool mnemonics on how to memorize the bacteria that fall under your atypical pneumonias and typical pneumonias, comment below, or just mnemonics for some of your pharmacology or pharmacotherapy, please comment below. As always, thanks for watching my videos, and I'll talk to you guys later.